holders on these questions. Now, in the first question, is it clear to Tanzanians that quality of care is an integral part of UHC? Our members, what we gather from our members when you talk about UHSC, they'll relate it to medical insurance. So they will think about financing. Many times they don't talk about quality. So maybe most Tanzanians do not expand the understanding of UHSC more than talking about the financing part. All right? We will see how this happens and why it is important that discussions should be expanded beyond financial protection. Right? We understand that, and this is why I shared the definitions before, when we are talking about UHSC, there are at least 4 very important elements. One is access, the other one is coverage, and then financial protection, and most importantly, quality of care. So the discussion around UHSC needs to encompass all these 4 elements. But unfortunately, what we usually receive from our members, the way they perceive UHSC, is about medical insurance, ensuring that everybody contributes to the medical insurance. But I think the discussion needs to go beyond that. So there is a need that our public discourse on UHC should go beyond financing and incorporate quality of care, because at the end of the day, UHC aims at ensuring that health outcomes are achieved. Now, when you talk about health outcomes, quality of care needs to be there. It's extremely important. Now, why is it important to ensure that quality of care is mainstreamed in the UHC agenda from the beginning? There is evidence, and a lot of literature has been given, but I've shared with you a literature here. There's a report written by WHO, OECD, and World Bank entitled Delivering Quality Health Services, a Global Imperative for Universal Health Coverage. And they have summed up what they have reviewed from different countries all over the world who are trying to be compliant by the year 2030 in ensuring that UHC is adopted. And in that document, they're saying the need for having quality of care embedded in the UHC from the beginning is imperative. So there's no question that this discussion can be postponed. I was happy yesterday when I was listening to the minister. He said among the 3 things that they are going to, the ministry is going to focus on, it's about quality of care. I guess you also heard about that. And I think that brings this discussion to an important, pivotal time. So I think we cannot postpone it anymore. Now, again, the aim of UHC is to achieve health outcomes, as I said earlier. Poor quality services, even when they are made at affordable cost, they are still going to impede the achieving of effective universal health coverage. So having services that are poor is still detrimental into establishing a sustainable UHC, right? So the issue of quality of care needs to be at the center of the efforts that we do as a country to roll out UHC. Now, this again is a quote from WHO, and the reason that they're giving is because communities will not use services that they mistrust and that are of little benefit of them. Now, again, discussing this from private health sector point of view, assuming that so many people will have access to financing, and therefore we are expecting many people to be going to the facilities. Now, the way the private sector is looking at it, if so many people come to the facilities without important elements of quality being improved, that is, having healthcare workers, having devices, having infrastructure in place, and having all the other important elements that we will discuss in place, then even though people will access the services, but the services will not be of quality. And therefore, health outcomes that will result will not be those that are desirable to the clients. And that is contrary to the aims of UHC. So it's not uncommon to increase access and coverage without increasing achievement of health outcomes. This is logical, and therefore the issue should not be only accessing services or ensuring that everybody gets services, but what kind of services? Are services responding to the needs of the people that go to our facilities? That is an important discussion. Now, why is it important to ensure that quality of care is mainstreamed in the universal health care, in universal health coverage agenda from the beginning? In the experience that we have had as participants in the quality improvement programs, we have realized that quality of care is very, very important. And I've shared with you in summary some elements that are confirming this. Like, the issue should not only be that you have healthcare workers, like if in a facility you have healthcare workers, that does not necessarily mean that people who are attending the facility will get the services that they require. All right? So having healthcare workers is not tantamount. All right. It's not tantamount to good quality of service. All right? And there are a lot of literature that are also showing that some of the health professionals that we have, sometimes they don't follow the protocols, they don't follow the procedures, the prescriptions are sometimes wrong, all right? Diagnosis can be inaccurate, and all those things. But UHC requires that the services provided are effective, meaning that they are compliant with standards. They are given in a manner that marries with the knowledge and the prevailing guidelines that are there. Again, safety is very important. We have cases, and this again is an experience that we have had with our members, where people going to seek for services are ending up getting some infections from the facilities. I think this is not a new thing, right? But again, we have to talk about safety of healthcare workers as well. So this cannot wait. When we are talking about UHC, we have to talk about safety. Safety of healthcare providers, safety of patients and people who are accessing our facilities for healthcare services. But again, and I'm happy that this was also mentioned by the minister yesterday, there's this thing that we call people-centeredness. We are lagging behind in Tanzania in terms of having hospitality in hospitals, right? How do health professionals handle the patients? Do they incorporate the needs, the opinions, the comments of the patients in the way they serve them? Is the service given people-centered? Because this is, again, an important element. If we have to make a leap in terms of improving quality of healthcare, then the way our health professionals are providing their services must take into consideration the concerns and comments and the needs of those people that they serve. Right, we have issues of timeliness. A lot of time is being wasted in terms of patient waiting time and patient turnaround patient turnaround time. All these things have a lot of implication in terms of customer care in our facilities. These are issues that need to be brought into the forefront from the beginning. So they have to be part and parcel of the discussion that we have in UHSC rollout. The issues of equity, ensuring that services that are provided are not discriminative. Everybody can access quality service regardless of the differences that we have, be they social, physical, or whatever kind of differences that we have. Yeah? We have issues of integration where we need services to be given in a manner that reduces cost. For example, today we are talking about comorbidities between NCDs and diseases like HIV and TB. We want to see things done in a manner where patients who are having several diseases can be handled in a manner that adds value. And then efficiency. How do we utilize the resources that we have? Are they cost effective? So all these discussions need to be dealt with. And that's why we are saying it is very important to ensure that the discussion about quality is brought into the forefront. There are other issues that we also need to consider, which I believe my colleagues will add as we go along. So, I have tried to expound on the 4 questions, and I think it will be of interest during discussions. There are 10 minutes that are added, so I'm trying to finish as quickly as possible. So, so that we have a discussion on those 4 issues. But what are the foundation of high quality care? What are the things that are required in the system? Because we are talking about ensuring that our healthcare system here incorporates quality of care. One is human resources, but not just a number of human resources who are motivated and supported to provide quality of care. Supported in understanding what they're supposed to do, given conducive environment to serve. This also includes remuneration and all those kind of things. So as we talk about increasing the number of human resources in healthcare, we need to talk about how are they motivated. There are issues of accessibility and well-equipped healthcare facilities. The equipment, how are they? Is it possible to maintain them? Are they well calibrated? Are they accurate? Okay, thank you. Issues of medicine devices and technology, information systems that are continuous to monitor and drive better care. All these things are required to be the bedrock of high quality care. And lastly is the financing mechanism that enables and encourages quality of care. And here it's not only about how do we pool resources, because yes, the country can be successful in pooling up resources, but that's only one side of the story. The other side is how are the resources that have been pooled up together channeled to the users. And here it's important to bring in the concerns of private health facilities, because the issue of UHC is public-private mix topic. So how are private health facilities going to be assisted in accessing these resources? Because as we speak today, there is a problem there. And I think experts will talk about it. So I will be ending, but I just wanted to say we'll be giving some recommendations. Before I do that, I want to provide some minutes for comments or for additional inputs from the panel here. It's unfortunate that most of our time was misused due to technology issues. So, can I open now the floor? If there are any inputs, any comments, any questions? I believe we still have like 7 to 8 minutes. Yeah. Judith, do you have any addition? Oh, there's a question from there. Do you have a question? No. Okay. Judith, do you have any comments? No. Dennis?
Just the point of addition on the issue of financing. It's real that we can having a lot of sources of financing, but in terms of quality, if we should not adhere with the standard and the adhering with the policy and procedure, thereafter the financing will all end up with the losses. Thank you.
Thank you. Yes, Dr. Do you have a comment?
For giving a very good elaboration of what quality means in universal health coverage. One thing that has always brought a lot of discussions in talking about universal health coverage is the issue of inequality. People believe that universal health coverage is for everyone, but some people might benefit more. And we've seen it happening today. When you go to a hostel and you see somebody coming with a card of Jubilee and they're given a special line, somebody comes with a card of VIP Member of Parliament, NHIF, and they've got direct access to the top hostels. And then the other one comes with a card of the Community Health Fund, CHF, and they said you can only go to a primary health care facility of the government somewhere in the village. And hawezi kwenda kwenye hospitali ile ambayo ni nzuri kwa sababu yeye ana kadi ile nini bima ya jamii. You get it? So people feel that will there be equality? Yes, we have not always been equal, and this is very clear. People will always drive a Corolla and somebody will drive a Mercedes-Benz, right? They're all on the same road. They're all going to where they want to go. They are all having transportation covered. And therefore, they can reach where they should reach. And the quality has been set for transportation. The quality set is the car should be safe. It should have brakes. It should not expose you to any risk of accidents. And the driver should be someone who is licensed. And the car should be serviced. That's what any traffic officer on the road will come and check on. Now, they will not check whether you're driving a Mercedes-Benz, you're driving a Range Rover or a Rolls-Royce, or you're driving a Corolla on the road. That's not a police officer's job. I do not care who is in the car. His job is to see that you are following the standard safety that has been put. Now, that is the quality you're talking about in healthcare. Setting standards that will enable everyone to get access to services that are safe and that will suit the criteria that has been put, that everyone should be treated fairly. And everyone should enjoy the 6 building blocks of healthcare systems. And everyone should have access to them. Now that's what you call quality. So we don't say that everyone should have access to Aga Khan Hospital or to Saifi Hospital, but everyone should get a hospital that when you go to Mwananyamala, you go to Temeke, you'll say you'll get the best set standards, the basic standards of healthcare that you need. And that will be provided to you by the qualified personnel with the right commodities the right medicines, not those that are reject and that are not only effective. You'll see a doctor who is qualified, who has got the same qualification, like the one who will see you in any other hospital you'll go to, the high-level hospital. And if you are going to get all investigation, they follow the standard protocols so that nobody make a mistake with your life. Now that's what we talk about quality of care in universal health coverage. And this is everyone's right. Doing anything less than that is going against human rights. So with that aspect in mind, we say universal health coverage is not a matter of money, of building good infrastructure, of building excellent buildings, 5-star hostels, but they should meet the minimum standards that are set for the quality that human beings should be exposed while getting their care, with the respect that they need. And for that is what we advocate and say that is important component and we must have it. Other buildings, blocks of universal health coverage, we know service delivery, it should be standardized and everyone should have the right to that. We talk about human resources, the people attending, those attending, the nurses, they should be standardized to make sure that they offer the right services at the right level that they're being set to. We're talking about medical devices. Everyone should have access to getting the best diagnostics. We're talking about other commodities financing. The government should consider that everyone gets a share of the taxpayers' money that goes to healthcare. And therefore, a percentage we put to cover for those who can't afford. And governance should be equally implemented to ensure that everyone gets the right person to oversee the healthcare services. And that's what we call quality for all in universal healthcare. Thank you.
Yeah. Oh, sure. Can you change the...
Thank you. My name is Gemera Mwemez. I'm the Executive Director of DAMAC Solutions. I'd like to appreciate AFTA for this great session. And thank you, Isaac, for the great points that you have provided. And I appreciate also the point that you have explained about the equity to ensure the quality, which I think to me is very critical when you're integrating the quality improvement as a way toward the universal health coverage. I think to me there are a few other points that is very critical to take note when you talk about the quality improvement with this integration into the universal health coverage. Number one, to me, I think quality improvement is an investment. And an investment that needs to be borne by someone. Someone needs to pay for it. Either to the government, or the users, or the investors. To me, I think that's very critical. Now the question is, who is going to bear the cost of the investment? I think now is where it comes the appropriate financing mechanism so that there is a win-win situation between the private sector and the government. In terms of how the National Health Insurance can dedicate some of the funding to support the private sector in order to ensure that there is an improvement in the quality of service delivery. So that to me is very important. The other kind of point that I want to make is about how do you consistently monitor and evaluate the quality improvement in the way to improve the access within the Tanzanian. I think one of the areas that we are lacking is in terms of the data utilization for the quality improvement. Again, it's an improvement. And to me, I think there is so many good innovation that out there which need to be taken into course when you're talking about the quality improvement, how it can be integrated within the health coverage. So to me, there are so many things that we need to discuss very broadly, but But I want to add those 2 points that to me I think are very critical. Thank you.
Thank you so much, Mr. Ngamela. I think you have added very, very important points. I think our time is almost over, but I just wanted to mention that quality can also can be embedded in the UHC agenda through the following. These are some of the ideas that need to be taken into consideration. And I think as a country, we need to consider this. One is to incorporate quality improvement as part and parcel of the UHC public discourse. It's good that we still have opportunity because the bill has not been passed yet. So the discussions that we'll continue to have as a country on UHC should put quality of care as a central thing in that discussion. But the second thing is we need to have a national quality policy and strategy. We have examples of countries all over the world, but at least we can talk about Ethiopia and Sudan, who have done a lot in terms of coming up with quality policy and strategy, because this will talk about so many things and put them in a structured way that as a country can align our approach to UHC. But again, it's time now to consider establishing a national healthcare quality accreditation body. If we have quality accreditation body, then the issues of ensuring that there is consistent monitoring of the facilities, the issue of ensuring that the issue of ensuring quality is not something that needs to be done by an external body, but it is taken by the facilities themselves. Okay, all right. And again, can we include some courses on quality of care in the curriculum of healthcare workers? I think that can add something. Most importantly, can we sensitize the public on the importance of quality of health services? Tanzanians need to know that they deserve a certain quality of service, and they need to make their choices wisely. All right? Thank you so much for listening. It's good we have come to the end of this discussion.
Good morning, ladies and gentlemen. Habari za asubuhi mabibi na mabwana. So, kama mnavyoona, we added about 10 minutes into the session, to the next session, which is going to be D3 CHV Health Forum in this Mikumi Hall. We are doing the same for this session. We are going to add 10 minutes into the break, so that we can recover the time that we spent in the morning doing some of the logistics and waiting for delegates. So if you're coming for the session for D3, I want to tell you that you're in the right place, and that these sessions are entirely managed by their organizers. As my colleagues are setting up the stage, we'll now like to invite the moderator for the second session to be ready and to welcome their speakers. We also want to let the moderator know that they are the ones who are going to entirely manage the session, including the way the speakers are going to spend the time that is allocated to them, and that when we are about 15 minutes to go, that's when you're going to see some of us coming to nudge you about the time. So for the second session for D3, the time now is running, and karibuni sana. I'm sure you have a moderator, and we are going to hand over the microphone. Karibuni.
I'm Halima Ali Hamisi from D3 International, a Senior Program Implementation Lead. And for today, I'll be a moderator for this session. Please receive greetings from Zanzibar. I'm here with my panelists. Actually, we're supposed to have 4, but Dr. Mtuli, maybe he will come afterwards. So for now, we have Dr. Slim. Dr. Slim, please wave your hand to the participant. He is the Director of Preventive Services and Health Education, the Ministry of Health in Zanzibar. And actually, he is a champion for CHV. You can't mention CHV in Zanzibar without mentioning his name. Dr. Slim, he is a public health specialist and has well experience on the provision of community health intervention in Tanzania and outside of Tanzania. And also we have our community health volunteers from both regions, Tanzania mainland and Tanzania Zanzibar. We have Sister Doesta, please wave your hand. She's community health worker from Dar es Salaam, mkoa wa Pwani, and she's well experienced in community health workers with high performance, and she has a good record of saving the life of mother and children, specifically under 5 children. And also we have Mr. Saif there. Mr. Saif, please. Also, he is a community health volunteer from Zanzibar, Pemba specifically. And also, he is best performer CHV. Always, he has good record from his community, but also for the Ministry of Health at all. So, welcome, my panelists. In this session, we'll focus on the integration of community health workers into national health system. Also, we will hear opportunity, challenges that come along with, but also we will have the opportunity to hear the future plan in both region, if possible. I mean, Tanzania mainland and Tanzania Zanzibar. We at D3, we are very pleased to have the government representative from both mainland and Tanzania, but also to have CHV from both regions. We are very happy to that. And today we are looking to explore our milestones that have been achieved through sharing experience for implementing digital supported community health workers program. Let me give you an overview of digital health improvement in Tanzania. For nearly 20 years, D3 has been working in Tanzania to change the way people experience care. We are working in collaboration with government and community to leverage digital and data to create a stronger primary health system. But for the last 3 years, D3 has been partnered with the Ministry of Health Zanzibar to develop, test, and scale up of innovative digital enabling community health system called the Jamii Afya. And even our community health volunteer, we are calling them Jamii Afya community health volunteers. Jamii Afya strengthens people-centered care, brings frontline health services to people doorstep, and ensure that all people, especially the most vulnerable, receive support and high quality of care. Since August 2021, the program has been scaled nationally, where a single and unified cadre of 2,300 SHV have been trained and deployed across all the district. I heard yesterday from Honorable Umbi Mwalimu, if Tanzania mainland still you are struggling to have single cadre of CHV, but thanks God, Zanzibar, we managed to do that, alhamdulillah. Currently, all Zanzibar population, they were served by digital equipped community health volunteer at their doorstep. The Zanzibar Ministry of Health has brought the country closer to universal health coverage now, just because of our CHV and some other intervention. But also, D3 has scaled up this digital health intervention in the Tanzania mainland. So in the mainland, in collaboration with the government of Tanzania, D3 and Apotheca have been working to address the health system challenge through innovative, first of its kind, healthy innovation that links the three key providers: community health workers, private sector, drug shops, and health facility in fully digitalized continuum of care. The system implemented through Afya Tech program improves the quality and coordination of care and the use of data across the public and the private health system. This is a short summary on how D3 scale up this digitalization issue and integrate it into Ministry of Health. Just I want to tell you, in Zanzibar, the community data have already integrated into health management system. So if you need any community health data, you can get through our HMIS. To link this statement, now just you can see why we need community health volunteers in our country. Zanzibar, but also Tanzania in general. We are still needing community health volunteers because we are still struggling with a lot of challenges pertaining to health care. We have inadequate resources for health. This is a global problem, but also in Zanzibar, for example, in Zanzibar, the place where I come from, we have shortage of staff for about more than 50%. Specifically now we have new hospital, we need more staff. But also we have poor referral systems resulting in a poor health outcome and avoidable death. But also we are suffering from cultural beliefs and misconception, specifically for maternal and child health. But we believe that CHV, they are trusted member from their community and they can resolve this cultural belief easily rather than healthcare provider. But globally, there is significant that if we are using community health volunteers, first of all, it's a cost-effective compared to healthcare provider, but also they contributed a lot on improving primary health care. Once if they are trained, equipped, and well paid, they can help us a lot. We are just trying, but we've seen the achievement. We are also struggling with the problem of inaccessibility of health services, specifically for marginalized and vulnerable groups. So most of maternal and child indicators are not reached. For example, now the indicator for nutrition in Zanzibar, our data said like 60% of the pregnant mother, they are suffering with anemia. All this happened due to malnutrition, maybe, or poor nutrition. or poor diet. But also still, we have imagined and reimagined disease outbreak. We have COVID-19, but also sometimes Ebola and other diseases. So, at this juncture, let me welcome my panelists again, and starting to ask a few questions to Dr. Slim. Dr. Slim, wake up, please. I know you are champion for community health volunteer in Zanzibar, but for community health intervention in general. Can you tell us the contribution of community health volunteers on improving health for the population of Zanzibar and improving health sector in general?
Yeah, thank you, Halima. Thank you, everybody that's here. To be honest, Halima has already made a foundation on the importance of this health cadre in Zanzibar and per se for low and middle income country. Zanzibar alone has a deficit of approximately 49% of our healthcare workers. And when I say that, I mean nurses, doctors, and the rest of them. Having CHV is a direct proportion to kind of lessen the burden of providing care for the nurses, which will allow them to attend into those most robust or rigorous innovation that the patient can come. But Halima has really outlined clearly that Zanzibar, with our context, due to economic and other parameters, which give people hindrance in terms of social determinant of health. So CHV become like a trusted neighbor within the community who really get to know the community and the context where they live. So going as to them, to the community, we really don't know their context. I will use an example. For example, when we, around June, July of 2021, in Zanzibar, we had abruptly of a measles outbreak. When measles come along, we start witnessing people dying and children who are either semi-dose or zero dose begin to die, and we got to the level of 16 deaths within the period of less than 3 months. And then we sat down during that time, we had an opportunity to have a polio eradication campaign. I sat down with my colleague to chair and making sure that we're going to integrate measles and polio together with vitamin A, because majority of those kids that were dying, they were either underdosed or malnourished. So we believe vitamin A is a precursor for immune system. So we use that platform to cascade our intervention. Furthermore, we use CHV to really go and do what we call behavioral science, because to have effective public health intervention, you require a social intervention and biomedical intervention. And social intervention is the one that actually make people feel okay to be vaccinated and why they're taking the vaccine. And the only people that we could trust to able to display that message was CHV. So having said that, when we went out there to intervene, it was much easier, and we got that community ownership in acceptance of our vaccine. And within less than 4 weeks, we begin to see a drastic fall in a prevalence of new cases of measles. And right now, Zanzibar has just been awarded a certificate from WHO as one of the measles-free destination. So this is one of the achievements. If we could just pack up and go with our cold chain supply, house to houses, we won't be let in by the community because they don't know. They don't know. So this health card, for me, is more like the front battalion for health. And without them, in the context of Africa and other low and middle income country, we will fail our way. So we must adopt them, and honestly, a small way of connecting a primary health care baseline down there in the pyramid. You must have CHV right before you go to the health facility, because this should be the first point of contact. And I do believe if we can all take a test at home using Rapid, I don't know why CHV cannot do that. There is no need for a patient to go and distract nurses who is overloaded at work just to do a rapid test for HIV and malaria. But then if you find out you got malaria, yeah, and you got other stuff, and you should be able to know what to take as well. So these are the stuff that really CHV, when they are fully trained, they need to be doing. And when we do that, we will only see people and attend to the nurses and make our nurses more effectively and efficiently, because not everything requires nurses attendance. So when we don't have enough capacity of specialized human capital for health, we really need to be innovative enough. And I think CHV is the right innovation to the way we are right now. And if we are to succeed in terms of delivering healthcare and reach the last mile, we really have to focus on this cadre. If that's not enough, Zanzibar, Halima has explained that we have a lot. We have a lot of problems, just like anywhere you are, in terms of maternal mortality. But let's look at the driver. On what drive to maternal mortality? We know hypertension is one of them, but also nutrition. They become the driver. And with the less resources that we've got in Zanzibar, it is through this CHV that is identified to us. In northern part of Zanzibar, women who are having complication of pregnancy and delivery are associated direct with nutrition, where when you are in the urban side, it's more hypertensive. So now we got the resources for the right place in the right context. We don't want to make one universal approach to this. So without this data they're collecting, we wouldn't be in a position to make those decisions, right? So again, I emphasize the important notation of this health cadre to make sure we go and actually reach the goal of universal health coverage for at least in Zanzibar. But I do believe we have a lot to learn from this individual compared to countries such as Rwanda, which has got probably same spectrum of healthcare cadre, right? But then they compensate their effort using this CHV. Today, Rwanda is the only country in sub-Saharan Africa which is closer to SDG 2030. If we mimic what they're doing, take into our context, I'm sure we won't be far from it. Thank you.
Now allow me to introduce Dr. Tumaini. Dr. Tumaini is Assistant Director of Health Promotion Service in Tanzania mainland. And actually, also I can say the champion for community health worker, because health promotion is the place where these community health volunteers are coordinated. So he knows in and out about HIV. Dr. Tumaini, we had a lot of things on achievement about community health program from Zanzibar. At this junction, we want to know the challenges for this program, I mean community health volunteer program in Tanzania mainland. Yes.
Thank you very much, moderator, and the floor for giving me an opportunity. My name is Dr. Tumaini Haonga, as have been introduced, Assistant Director for Health Promotion Services in Tanzania mainland. I appreciate for giving me an opportunity to touch on the challenge with regard to community health programs, as well as where we are envisioning the government. Different from our brothers and sisters in Zanzibar, we are using the term community health workers, while they are using community health volunteers. So we have CHW and the CHVs. So in our write-ups and different documents, you find we are writing CHWs, but we are referring to nearly almost the same thing. And so in Tanzania mainland, as it is for Zanzibar and other countries, mainly in Africa, we are also taking an opportunity to make use of the community health workers in implementation of primary healthcare programs aiming to achieve universal health coverage. This is in the areas being supported by the community health workers, like supporting health education roles at the community level, household visits, linking communities and health facilities, but also supporting basic promotive health services at the community level. These community health workers have been used in different interventional areas, like supporting communicable diseases, non-communicable diseases, but also emerging and re-emerging disease conditions, as well as aspect of reproductive, maternal child health, family planning, sexual reproductive health areas, and other component of the social protection and the basic social services at the community level. So on the side of the mainland, the program has been faced by several challenges, but the main key challenges are three. The first is on the aspect of coordination, which is linked to the second challenge of fragmentation, of which you find these community health workers are not well coordinated in some of the areas. That has been for a long time. On the aspect of the manner how they are trained, the number of days for trainings, but also how they are being paid, those disparities, provision of the working tools to support their roles. There are some disparities depending on the vertical programs and the one who support the programs. But in the same regard, we have the challenge of sharing information to the large scale, to what the community health workers are doing. And so we have some best practices in this area. For instance, moderator, through the D3, the Ministry of Health has been implementing the AFIATEC program in the coast region, which is 40 kilometers from here, in the two districts of Kibaha, TC, and the DC, where we have made use of the management information system to support community health workers' roles. In linking the project is being done in a tripartite mode, where we link the communities, health facilities, but also the accredited drug distributors, the ADO. But then their roles, implementation, and reporting, including data, are being channeled through the management information system, which we have studied it and considered to think about integrating and scaling it up to other parts of the country as a best practice. Since currently, the government is envisioned to have a new program, which is an integrated and coordinated community health worker program, which is going to address all the challenges I have mentioned. And this program is due for starting implementation. All necessary arrangements have been in place, in collaboration with the PORALG, President Office, Regional Administration of Government, development partners, and implementing partners, of which this program will address the challenge I said. The key issue with the program is implementation in an integrated manner, where community health workers will not only be specific for one interventional area. So the deployed community health worker will support a variety of health areas in the state catchment area. And in that regard, we do not expect that we will have one community health worker who is having a tablet, like a tablet for malaria, a tablet for TB, a tablet for HIV, a tablet for family planning. But then those 4 tablets will save 4 community health workers under this program instead of saving 1 community health worker. And also, regarding the training, we are standardizing training to have them trained for a cumulative total of 3 months, so that they can save variety of areas. And in the case of payment, we are in this program, they are going to be paid monthly incentives, which is standardized, and the ministry is going to issue a government circular regarding the community health workers' scope of work and the practice, and other key issues like the modality of payment, amount to be paid, aspect of training. And in a nutshell, for instance, our data shows to train one community health worker, previously you could find some programs could cater for about 4 million and the like. But through this approach, we are going to lower the cost to 2.3 million through the training which is being underway. So this will support government effort and the area supported by partners to address the challenge in the community health practice, mainly to promote social behavior change, community linkage, and deliver health promotion initiative, and other aspect of basic curative services at the community level, where the community health workers will be supporting this initiative, but under supervision of the skilled health workers from the catchment health facilities. So this is how we are envisioned, and currently we are continuing with advocacy, but also disseminating the detail of this program to different stakeholders so that we are in one page and move together to implement this. This is also a global call to strengthen community health programs to achieve universal health coverage. Thank you very much, moderator.
Okay, thank you, Dr. Tumaini, for sharing challenge, but also you add some achievement. And now I think the audience will know that community health volunteers, they are doing a lot and they are saving the life for our population. Community health volunteers, they're providing like risk communication and community engagement, but also they are doing like community-based surveillance, specifically during the outbreak, but also they are facilitating referral, especially for those who have a danger sign for mother and under 5 children. But also they help us to link between health facility and the community, but also community health workers, they are the one who identify the most of the outbreak in the country. If we take into example, when we got the outbreak of measles in Zanzibar, the first case were reported by our community health volunteers. So you guys were doing a good job. Thank you very much. And as I have told you, today we have our community health volunteers from both regions, Tanzania mainland and Tanzania Zanzibar, so that let's hear from the horse mouth now. Bwana Sefu, habari? unajisikiaje kuwa hapa?
Habari njema na najisikia vizuri kufikia hapa.
Sawa. Tumesikia mazuri mengi ya kwenu ambayo yamezungumzwa kuhusiana na utendaji wenu wa kazi, lakini vikwazo ambavyo vinakumba wizara, kumba wadau mbalimbali katika kuhakikisha hii program inakaa sawa na mnaweza kufanya vizuri. Na najua mmefanya mengi mazuri huko mlikotoka. Je, unaweza kushare successful story yoyote ambayo umefanya au umetoa huduma kule katika jamii yako kutoka kuweza kuambia audience hapa wako kusikia?
Ndio.
Karibu Bwana Seif.
Asante. Kwanza awali ya yote sinabudi kumshukuru Mwenyezi Mungu, muumba wa mbingu na ardhi, lakini pia akatujalia afya njema tukafika hapa tukiwa wazima. Lakini kwa kuendelea tu labda mimi niseme kwamba community health volunteers tuna mchango mkubwa katika jamii, katika kuhakikisha kwamba jamii za Tanzania zinapata afya bora. Mimi mwenyewe ni shuhuda wa kwanza ambaye nilimkuta mama ambaye ni mjamzito na alikuwa na ujauzito wa miezi minne, lakini katika hali ya kuzungumza naye pamoja na mwenza wake aliniambia kwamba anatokwa na damu, wakiwa wanaamini kwamba ni sehemu ya kupunguza tu katika ujauzito. Wanawake wanasema kwamba anapunguzia, anapokuwa mjamzito akawa anatoka damu katika sehemu zake za uzazi, wanasema kwamba anapunguzia. Kumbe haikuwa kwamba ni kupunguzia. Hii ni moja ya dalili mbaya za hatari kwa mama mjamzito. Kwa hiyo nilichokifanya kwanza, nilijaribu kueleza uhalisia wa kile kitu kilivyo, kwamba hii ni dalili ya hatari na tukiendelea kubakia tunaweza tukapoteza maisha ya mama, lakini pia tukapoteza maisha ya mtoto. Sasa cha kufanya mimi nikawashauri waelekee kituo cha afya kwa ajili ya kupata huduma. Kabla ya kuondoka wao, mimi nikatoa simu ambazo tumepewa kwa ajili ya kutuma taarifa, nikatuma ile rufaa kwenda kwa daktari wa kituo ili aweze kutambua kwamba kuna mgonjwa anakuja kutoka katika jamii ana tatizo fulani. Jambo la kufurahisha sana kwamba baada ya kutumia simu, manake taarifa zimefika kwa haraka na kwa wakati unaotakiwa. Daktari naye pale pale hakuchelewa, akajibisha kwamba amepata hiyo taarifa na yupo tayari anamsubiria mgonjwa afike. Baada ya masaa mawili mbeleni kanipigia simu, kuna mtu amefika hapa lakini yupo na mwenza wake. Nikamwambia jina lake nani, akanitajia jina lake. Nikamwambia ndiye sahihi, naomba msaidie. Daktari akaanza kufanya naye mazungumzo, akajaribu kwenda kumfanyia vipimo, akagundua kwamba ni kweli ni dalili ya hatari. Sasa baada ya pale akampatia dawa aende kutumia nyumbani. Alikaa baada ya siku 3, mimi nikapata message katika simu yangu kwamba natakiwa nirejee tena kwenda kuhakiki ile rufaa ambayo nimeitoa. Kwa nilipomrejea mama akaniambia ile tatizo damu imepungua kutoka lakini bado inaendelea kutoka. Nikatoa tena rufaa kwenda pale pale kituo cha afya ambapo alienda ni mara ya kwanza. Alipofika daktari naye pia hakuiweka tena ile kesi, ikabidi aipe rufaa kutoka kwenye kituo cha afya ikaenda katika hospitali ya wilaya. Na alipofika hapo yule mama akabidi apatiwe kitanda kwa muda wa miezi 3. Na actually nashukuru sana, baada ya miezi 3 alitimiza kama miezi 8, akaambiwa tunaomba urudi nyumbani, lakini once ikitimia tu tarehe ambayo umetakiwa kurudi kwa ajili ya kujifungua, usibaki nyumbani na urudi hospitali. Naye pia nashukuru hakuwa mbishi kwa lile, muda ulipofika alirudi na akajifungua mtoto wake akiwa yuko salama na yeye mwenyewe pia yuko hai. Labda kwa hapo mimi niishie hapo, naomba kuwasilisha.
That's a good job, man. Good job.
Asante Bwana Sefu kwa story yako nzuri. Nadhani tumeona how CHV they can save life of mothers and children and how they are doing
very good job at their community. They are struggling a lot. Sometimes they are using their own resources just to make everything to be clear and just to save the life of the mothers. Sometimes they told us they use their own money to facilitate the referral, but that is the good job, and the God will pay you. And now let's hear from Dostia, our community health workers from, every time I forgot the name of your place, Kibaha. Okay. Just tell us, tuambie story yako ya mafanikio katika kazi zako. Tunajua una uzoefu wa miaka 6 katika kazi hii. Bila shaka ushawahi kukumbana na changamoto, lakini na mazuri ambayo umeyafanya. Maybe you can proud yourself, nimefanya kitu kizuri, na unaweza ukahadisia familia yako na pia ukahadisia wadau wengine, na leo tupo hapa tunataka kusikia pia. Karibu.
Asante. Kwa majina anaitwa Dostea Lonjina Lunyungu, ni CHW wa Kibaha, mkoa wa Pwani. Kwanza namshukuru Mwenyezi Mungu kufika mahali hapa. Kama CHW kupitia D3 tunafanya kazi pamoja na Afya Teki. Tuna program ambayo kama CHW tumeingiziwa kwenye simu zetu, ambazo zinatusaidia sisi kufanya majukumu yetu kwa urahisi zaidi. Yaani teknolojia imetusaidia sana. Kwa sababu zamani tulikuwa tunatumia sana madaftari, makaratasi. Unavyoenda kuwatembelea kaya zako zile ambazo unazihudumia, maana tumegawanyika, tunakuwa na zile kaya. Yaani familia ambazo tunakuwa tunazitembelea mara kwa mara. Imetusaidia kwa sababu zamani tulikuwa tunatembea na madaftari na makaratasi. Ilikuwa ni rahisi sana kupoteza taarifa za mgonjwa, kupoteza taarifa za familia zile ambazo unazihudumia. Lakini sasa hivi kupitia teknolojia za smartphone ambazo tunatumia, imekuwa ni rahisi sisi kama wahudumu kuwa na taarifa kwenye simu, na pia imeturahisishia kutokuwa na muingiliano wa taarifa. Yaani kwamba mimi mhudumu nikiwa tayari nimeshazisajili kaya fulani, inakuwa ni ngumu kwa mhudumu mwingine akipita kuisajili ile kaya, kwa sababu naye kwenye smartphone yake itamuonyesha kwamba huyu mtu ameshasajiliwa na mhudumu mwingine. Kwa pia teknolojia imetusaidia sana kuturahisishia katika kazi zetu. Lakini pia teknolojia pia imetusaidia katika kazi zetu, kwa sababu zamani tulikuwa tukienda unakuwa ile kwa hisia, unahisi kwa akikwambia kwamba mimi na tatizo 1 2 3 na 7 itakuwa tatizo fulani. Lakini sasa hivi kupitia simu zetu, kupitia hii teknolojia, mfumo ambao wametuwekea katika simu zetu, kuna zile dalili za mama wajawazito za hatari utaziona. Dalili za watoto walio chini ya umri miaka 5 za hatari utaziona. Dalili za kawaida utaziona. Kwa hiyo ukifika kwenye kaya ambayo unaihudumia, for example labda nikaenda katika kaya ambayo ina mama mjamzito. Zamani wamama wengi walikuwa na ile mentality kwamba kuwahi kwenda hospitali mapema ukiwa mjamzito, yani zile follow up za mara kwa mara kwenda kliniki huwa hawapendi. Mtu anaweza akakaa nyumbani mpaka mimba miezi 6 ndio akakwambia kwamba anaenda kuanza kliniki. Lakini kupitia sisi CHW, kupitia mafunzo ambayo tunapewa, semina zile, imetusaidia tunapozunguka katika jamii kuwashauri wamama wajawazito. Zile wiki 2 tu za kwanza anapojihisi kwamba yeye ni mjamzito, basi hawahi kwenda kituo cha afya ili aanze kliniki na kumsaidia kupata zile follow up za mara kwa mara mpaka atakapofikia kujifungua. Kwa hiyo imetusaidia sana kupunguza vifo vya wamama wajawazito. Na pia kwa kupitia hii teknolojia ambazo tumewekewa kwenye simu zetu, inatusaidia ninapoenda kumtembelea mama au mtoto, ninapokuta na dalili za hatari, ninapompa referral ya kwenda kituo cha afya, referral yangu inakuwa inafika kule kwa haraka, tofauti na ningemwambia tu aende hospitali yeye mwenyewe. angeenda kule, angeanza kupanga foleni mpaka afike kwa daktari. Lakini ninapompa mimi referral ya kwenda kituo cha afya, tuna masupervisor pale katika vituo vyetu vya afya ambao tunafanya nao kazi, ambao pia nao wana mfumo pia wa teknolojia kama tulionao sisi. Kwa hiyo anavyo message ile inapoingia, anagundua kwamba kuna mhudumu wa afya amempa referral mama mjamzito ambaye labda anatokwa na damu au labda ana maumivu makali ya tumbo. Kwa hiyo akifika pale yule mama, ni rahisi moja kwa moja supervisor kumpokea na kumpeleka kwa daktari kwa haraka na akapewa huduma kwa haraka zaidi. Kwa hiyo teknolojia imeturahisishia sana katika ufanyaji wetu wa kazi. Lakini pia mimi kama kijana pia katika mfumo wetu tunaofanya kazi, tuna vijana adolescents ambao tunawahudumia katika jamii. Mimi naishi Pwani. Pwani vijana wengi, kuna ile mentality ya vijana kutotimiza miaka 18 kwa mabinti, unakuta wanapata mimba za utotoni. Zile mambo yetu ya unyago, mambo mbalimbali ambayo wanafanya kutokana na tamaduni zetu. Lakini kupitia mimi kijana mwenzao ambaye nimepata mafunzo, ninakuwa na ukaribu nao zaidi, na inakuwa kwa uhuru wao tunaweza tukaongea vitu ambavyo kama kijana hawezi kuongea na mama. Yaani namaanisha mfano labda binti akajihisi labda ni mjamzito, au akajihisi labda katika labda vyake vya uzazi labda kuna uchafu anatokwa, au kuna dalili ambazo ni mbaya hazielewi, inakuwa ni ngumu kuongea na mtu mzima. Lakini anapokutana na mimi kijana mwenzake, inakuwa ni rahisi kufunguka na kusema changamoto gani anazozipitia. Hiyo inanisaidia mimi kumcancel au kumshauri kwamba sasa kutokana na tatizo hili ulionao, basi twende kituo cha afya akaonane na daktari. Hii imetusaidia sana kupunguza hata zile mimba za utotoni, lakini pia kupunguza uwezekano wa mimba zisizotarajiwa, kwa sababu tutamwelekeza kwamba family planning, kuhusiana na masuala ya uzazi, atachagua njia gani ni rahisi kwake atakayoitamani kuitumia baada ya kufika kituo cha afya, kwa sababu pale atakutana na madaktari ambao watamueleza zaidi. Asanteni.
Thank you very much, Dostia, for the good job you have done in our community. Congratulations, both of you. Dostia just explained to us how digital health improving the primary health care service by facilitating referral and linkage, and also by data storage, improving data storage. And actually here we are working with a call of action from Liberia. We are insisted to improve knowledge of our community health workers by involving them in a different platform and summit. That's why they are here. Since they came here, they learn a lot of things, and they continue to learn. And also, there is a call of action to recognize CHV. And also we needed to provide the long training to them to help us at least to provide a simple curative and diagnostic service at that particular community. To improve technologies, but also as a government or NGOs, organization, we have to mobilize resources to them in order to be comfortable in their work. Thank you very much. I think we had a lot concerning to achievement, challenges, and also we had the voice from the CHV that they are working at the ground. But now we want to hear about the future plan of Community Health Volunteers Program. We will start from Dr. Tumaini and we will end up with Dr. Slim. Karibu, Dr. Tumaini.
Asante. As I narrated earlier, the future plan with regard to community health worker program, mainly for the Tanzania mainland, we are going to implement the so-called integrated and coordinated community health worker program, under which there are key aspects to community health workers in the areas of training, where we are going to have standardized integrated training, which lasts for 3 months, theory and field practicals during the training, but also 3 months attachment at the village or hamlet level, while being supervised by the supervisors from the health facility and the trainers. That is one. And this training costs 2.3 million for one community health worker to completion. And the other areas is deployment, where we are going to set the standardized monthly incentive to community health worker so that they are paid every month and deliver integrated services at the community level. The third issue is on the information sharing. We are making use of the data, as I mentioned earlier, learning from the feedback and the experience of the systems which were used on local scale to scale up and use them at the national level, countrywide, to improve on the management information system, supporting reporting, data collection, and also follow-up of the implementation of the community health workers. And the fourth aspect is on the working tools. We understand we have the standardized package which defines the key working tools to community health workers, like the uniform, data collection tools, reporting forms, but also mobile applications for storage and use of data in the management information system and sharing. The fifth area is on the continued supervision of the program and in-service trainings. We understand it after deployment, we might need to do some refresher trainings to the existing community health workers, which is also a part of this program. So in a nutshell, the current program aims to address those areas, and the Minister of Health has been collaborating with President Office, regional administration, local government, as well as implementing partners and our development partners funding the program to implement these future interventional areas. But the modality of implementation, this will be phased depending on the availability of resources, but also on the prioritization of the health indicators at the level of the districts as well as the region. So the mapping has been done, and it is guiding us on the manner of starting the implementation of the program. It will have a national launch by the high-level government leaders, expected to take place in 1st of January next year. So we have 3 months of final preparation to roll out this new program. You are warmly welcome. And in that regard, I also appeal to community health workers and request them to continue executing their task depending on the guidance provided by our counterpart at the local government authorities and implementing partners, while this transitioning is ongoing, and we are going to make sure that those who are in the program are given a special priority to continue supporting communities in the delivery of services. Thank you very much, Darim.
Thank you very much, Dr. Tumaini. it seems the future is glooming, as we are using to say, Zanzibar, yajayo yanafurahisha. So now we want to hear from you, Dr. Slim. What is your future plan of Zanzibar concerning to community health volunteer program?
Yeah, thank you, Halima, and thank you everybody on the floor. Obviously, we have explained earlier on what we have already achieved in both of this CHV, that what they have explained here is enough evidence to allow us to conceive that they are very important to our health system, especially in universal health care. We in Zanzibar, we have 2,300 community health volunteers, and they're covering around 1,000 population. And we plan in our roadmap to increase to double their number, to allow them to really focus on 500 households, so that they will do rather quality work rather than quantity of work. But like I explained to you, right now we have stuff like rapid diagnostics and other parameters that simply you can able to do it yourself at home. Those parameters, the simple diagnostic, we really try to shift it to CHV in order to reduce the work burden to our nurses, so that they can focus on their really core function, which will allow them to provide better service of care. Furthermore, we have already in the plan to really put CHV at the bottom of the pyramid of our health system. So we plan to have community health work at the bottom, and then we will have health facility, health care, district hospital. So there will be the first point of referral. We automatically, by doing so, reduce the influx of patient at the facility, reduce the influx of patient at the district hospital, and only those who require referral at the regional and super specialist, they will do so. At the moment, in Zanzibar, we had chaos. We had people who just need wound dressing. They're showing up at a referral hospital, which impaired a lot of weight to the service provider in those hospitals, and therefore the service might be compromised. By doing that, the other projection, we do expect to see different change of paradigm to allow patient to be addressed, known, like he explained. He identified the patient problem based on his context at his community, and they understand each other in their own language. And then that patient was convinced that he was being cared with the right person, and listen and go to the health facility. The health facility intervened, but the intervention was not enough. They follow each other's up, knowing that case now need to go further up. And this is how we should be doing. And if we continue to do that, automatically everything will change. Our mission and vision in the Ministry of Health Zanzibar is really to lift the barrier for social determinant of health, right? If it's education, we allow CHV to go and give people knowledge. If it's vaccine, we allow CHV to go there and identify those 0 kids and half-dose kids, and we go and intervene. Currently, we have a lot of plan in places, right? But without this first battalion, whatever we're going to be doing in terms of biomedical intervention aspect will fail if we don't have the social aspect for them. But like I say, they will do the social part, but we will enhance them in terms of their training to make sure that they do other of those parameters to ensure that nobody is left behind. Yeah. So, but furthermore, we have a roadmap, which is a transition. The government is planning to adopt this health card, right? It's not going to be a CHV anymore. We are planning to make him to be part of the integral part of our health system, and we get recognized as CHW, where they can be stipend and they can able to be equipped and receive proper training to allow them to fulfill their obligation accordingly in high level of professionalism. So we have a frame, and we manage to find resources, even though they are not enough. So we will probably try to seek for more resources to allow this to get benefit, which is correspondence to the service they render to our community. Our country holistically want to make sure we really reach the target of SDG, from vaccine level to reproductive level to other parameter of preventive service, so that we'll have less community going into curative, which is the most expensive and require a lot of intervention for a long time for any government setting. So the way forward, in our way, is to deploy twice as much as CHV in Zanzibar, making them up to 5,000. And Halima mentioned I'm a champion, but no, the minister himself is a chairperson leading to this. I'm just assisting him with the assistance of my deputy director to allow this effective innovation to be able to be implemented in the most effective way and in effective time. So we do believe probably once they have been inaugurated, as per my counterpart there, we will begin to see changes. The changes are already there. What we see right now in terms of maternal mortality, ANC visit, if we could have plotted a mathematical model and take away CHV, this could have been seriously problematic. So what we see right now is an improve, right? But the improved version that require improvement, right? So we really embrace the fact that we have CHV, and I do believe solemnly that this individual are the probably most needed entity in terms of our health system strengthening. And if we train them right and equip them right, having said that, they're already committing their own cash to do things. There is inner passion in them already. And believe you me, they're only getting 50,000 shillings, right? And they still stay in the game for over now 3 years. So if we top them up properly, right, and allow them to be more trained, their passion will show, and we will probably be benefited more out of this individual than we can imagine. So with that being said, without further ado, I would like to thank everybody here who participated in this symposium. But I will also like to see if we can able to have more stakeholder to participate in supporting this. The government is having a plan, but it's not ready to fully adopt this health card. And to be honest, few of them have shown an indicator of dropping out. Yeah, we have to kind of keep looking and hire them. And unfortunately, they're human. Some of them die. And we try to make sure we have the same number all the time. And to do that consistency, they really need to be incentivized and make sure they are rewarded for what they are doing. Only then we can have something that is sustainable to ensure that we are reaching the goal and aspiration of our government for universal health coverage. Thank you very much.
Thank you very much, all the panelists. And here is the end of our presentation. We allow a few questions from the audience. Karibu.
Thank you, Halima, for the moderation. I think it has been a very exciting engagement right now. I am Edward Zimbe from Living Goods, and I lead programs across the regions where we operate. So whether it's East Africa, West Africa, and everywhere else we operate. It's such an honor for me to be here today and to listen to what is going on in Tanzania. I have questions for Dr. Tumaini as well as Dr. Slim. And it's related to impact at scale, which is a critical focus for us because in all the regions where we operate, We actually partner with governments, but also partner with other already existing partners to enhance scale through community health work, focusing on universal health coverage. Now he's mentioned, Dr. Tumaini, you've mentioned how there is a plan in January to launch the integrated program on community health. And I'm curious to understand a few things. Firstly, is it completely funded by government, or do we have also partners providing the support? Number two, is it going to cover 100% of mainland, or is it going to start with the two districts, the coastal districts that you mentioned? And then number three, for the integrated package that you're talking about, you've mentioned about them being paid, the training, the supervision, and I just wanted to understand when it comes to the digital tools, because you talked about the information systems, and I wanted to know whether government is leading this or you're working with a partner, for instance, D3 that has got great experience in doing this. Is it something that the government is going to work with? And are these systems interoperable with the DHIS2, the already existing health information system? Is it working together? Just to understand how that is going to operate. And then maybe my question to Dr. Slim with respect to the scale that you're talking about. I just wanted to know whether the government of Zanzibar has already budgeted for this, whether you have timelines for this, and whether all, the digitization is 100%, and whether this is something that the government is going to take on, or you're going to continue, leveraging support from partners like D3. Thanks.
Thank you very much for.
Hello, my name is Joseph Mwashemi. I'm coming from FHI 360 and EPIC project. Thank you so much for a fantastic presentation and the achievement you have demonstrated in your presentations. I have two questions. One, are there any specific pre-qualifications for these community health volunteers and community health workers? Is it the same or different? I would really like to know on that. And also specifically to Dr. Slim, you have demonstrated that these community health volunteers, they do a great job in community mobilization, community sensitization, referrals and linkages, basically on the social parameters as you have mentioned. But specifically, as you say, they are relieving some of the work from clinical or healthcare workers, nurses. That has been really a challenge to determine, especially from mainland and other places. What specifically task shifting are you shifting from these healthcare workers? If you can give a few examples, apart from the good work which they're doing on community sensitization, linkage, and mobilization. Thank you.
Good morning. Good morning.
Morning.
I'm Queen from Farm Access. The previous participant asked on interoperability, but I just want to be a little more specific because now you're calling on to developing partners and other stakeholders to come and support in all this CHW intervention. But then my real question comes in. You know that when we call up to stakeholders, they all come, everyone is going to be interested. But then how are we going to manage the stakeholders, how to map appropriately, like who is doing what, and maybe try to interlink partners who are doing the same thing? Because we see that as a challenge in Zanzibar, a lot of partners are doing almost the same thing, but NCHW have a lot of fragmented, there's fragmentation of activity. She's nodding because she knows what I'm saying. But it's really a challenge. I don't know how the government can help to regulate because now they are
Asante sana wawezeshaji. So my question goes to, I think, Dr. Haonga. We are thinking about this integrated package, a community health worker who will have the whole package, like when there's immunization campaign, the person will work. HIV issues, we have to go for it. TB, we have to go for it. Nutrition, we have to go for it. Maternal and child health, they need to go for it. And probably we will be paying this person, but this person, since he's still a volunteer, may still need to be having some time in his or her life to earn other maybe incomes for his or her living. So do we think this is feasible in terms of capacity and maybe time availability and efficiency? Can't you probably think maybe group or categorize, maybe limit a package? Say maybe this integrated will have 3 components. So that if you are in a village or a street, you may be having 4 or 3. And then not that all of them will be doing similar things. So that you can increase efficiency, but also give time for this person to do his or her work. The other thing, we also thought of engaging some employed middle level, low level cadre of healthcare, like the nurses or the clinical assistants who have a certificate or a diploma, who are still not in the formal public employment system, if they can also do some of the community work, because these people are already trained. You may not need the additional the 2.3 million, so that maybe you can use the available 2.3 million to incentivize more these existing community health workers who have been trained for 3 weeks or a month or 6 weeks, so that they can continue doing the good job they are doing, and the people who are trusted and they can be retained easily. Swali jingine labda kwa wahudumu, niwapongeze sana, lakini ni ile kuuliza, je, hiki kinachofikiriwa kwamba wewe ufanye karibia kila kitu, ikija chanjo ukashiriki, ukapime watoto uzito uende, kuna kampeni ya kifua kikuu, watafuta watu wamepotea kwenye dawa za kifua kikuu ukawatafute, kwenye VVU au wajenda CTC ukawatafute. Utaweza? Asante.
Thank you. Sorry. Thank you. My name is Eleanor Ochodo from Kenya, the Kenya Medical Research Institute. Now, training, dissemination, and supervision of guidelines is often cited as a challenge to implementing guidelines for treatment and diagnosis for health workers, specialists, and even mid-level health workers. Could you elaborate further on your training, dissemination, and communication activities to community health workers and patients? Because I can imagine if it's a challenge for those who have got the technical expertise, it could also be a challenge to community health workers and patients. Could you elaborate on how you're doing that to effect implementation of guidelines for diagnosis, especially rapid diagnostics? Thank you.
Thank you all for your question. I'm very happy. This seems like you are very attentive during the presentation. Now is the time the panelists to respond to the presentation. There is a lot of questions have been asked here. There are questions about who will support the budget for CHV New Glass, specifically Zanzibar, but also there are questions for Dr. Tumaini. You presented here, you want to do some more inauguration or commemoration for CHV, who will support that budget? And also there are the question, how CHV will be master of everything to provide anything like immunization, healthy promotion, and some such other things, how we will plan our CHV to work effectively. And also other question for CHV wenzangu, vipi tutaweza kufanya kazi zote kwa pamoja na kuweza kufanya kazi zile zikawa nzuri kwa umakini na kwa ubora ambao unautakiwa, ikiwa kila mtu anatuhitaji sisi. But also there are other questions from the lady there, like how we can map our partners in order to work effectively, to avoid duplication, and to manage our resource. And also, there are other questions about criteria for selection of CHV. I think this will relate both Tanzania mainland and Tanzania Dar es Salaam. Maybe we have different criteria. So you are most welcome to answer the question. Who will start first?
Thank you very much, moderator and the floor. I appreciate for these very good questions and areas needing clarifications. So beginning with the issues raised by Mr. Zimbe on the areas, I start with the aspect of funding of the Integrated and Coordinated Community Health Workers Program. As I mentioned in my prior speech, the funding is both from the government and partners. So all stakeholders are requested to consider supporting implementation of the program. So it's a joint funding, but it is phased depending on the availability of resources, but also the prioritizations of the regions. We have regions and the districts we have made depending on the challenging health indicators. So the regions with more challenge on the indicators are given priorities for first implementation. So that is one approach we are doing. And the detail of the regional prioritization is available for sharing, and we can do that to our stakeholders. Regarding the selection of the district, I think I've clarified this. We are not only going to start with the 2 districts. This is a countrywide plan, and the focus is for the whole country, so different regions, different districts, but in a phased approach. The use of digital tools is expected to be a part and parcel of the program, making use of the current advancement in the technology, but also to simplify receiving information on the implementation part, as well as providing some message and the resource information to community health workers to support them with implementation of the programs. So the digital tools and the management information system are expected to be interoperable so that they will be linked to the other existing systems. And this system, the issue is to reduce the number of systems as well. So the aspect of interoperability is well considered and well featured. In ensuring this, we are working with different partners and other stakeholders, first to start the existing platforms and the systems. And that's why I mentioned that we have established that we have some best practices of the existing systems which can be scaled up. And I provided an example of the AFIATech D3 digital supported system. But also we have other systems like we have other systems in the community health which we can consider them to take some features and have one consolidated system. In the Mr. Joseph asked about the specific pre-qualification. So as I mentioned earlier, we are going to use an opportunity of taking the existing community health workers with experiences and who match these pre-qualifications. But the added criteria for those who have not been in the program is for them to be Form 4 leavers so that they can be part of the selection criteria. To strengthen management of stakeholders and the communication flow, Daktari hapa aliuliza, we have the Community Health Task Force, which is being co-coordinated by the Ministry of Health on one side, President's Office, Regional Administration of Government on the other side, and is composed of partners and other stakeholders. So through this Community Health Task Force, we shall have several technical advisory meetings to inform about the program and advise on the different aspects when moving forward. Regarding implementation of integrated services, the placement of community health workers is at the kitongoji level for the village, but the mtaa level for urban areas. So in one village you can have 3, 5, 6, 7 vitongoji, but at a kitongoji level we have 2 community health workers, male and female. And in population-wise, there will be saving. If a kitongoji will have 1 community health worker, will save 60 to 70 households with an average of 6 people benefiting the same household. But if they are 2, it means they will save 30 to 35 households each for the respective area. With that number of households, if we take an assumption of saving 10 households a day, it means you'll need 3 days of dedicated work by HV in a week. So that is an assumption. And we think, and also studying the ongoing practice, this is implementable and is implementable. But during implementation, we'll have implementation research to start and have evidence on how best the program works, especially on the first enrollment and the intake. So that is the plan in place. Regarding the use of other skilled workers, if who wish to be part of the community health workers, they can enroll in the program. And when they meet the selection processes under the local government authorities, because the selection will take place at the village and the mtaa level and the ward development committees, using the guideline issued by the government. I think I have touched all issues. Thank you very much.
Thank you. And actually, the time is not in our side. Just select one strong question and answer to them. Dear audience, Dr. Slim is still here in the summit. You can reach any time and they will provide your answer. Even our CHV, they will be at their booth there, outside. They will answer all your questions. For the sake of time, just one.
Okay.
Yeah.
Thank you. I probably will touch the question of the gentleman, which also relate to yours. It's a tough job to be able to mimic this professionalism of doing the diagnostic from CHV. But let's be fair. The reason why we're struggling is because we have lack of human capacity, right? This is the way it is. You know, we go to the hospital, our nurses are fully populated with patients, and where those mothers who require their attention is now being divided to other issue that probably somebody could literally do it at home, right? We test our HIV status in your own home. You can take your partner to the accommodation and test them for HIV and know their status, right? You can able to literally test your own blood pressure, right? And these are the stuff that are happening in the health facility. And probably majority of those people show up crowding the health facility, require those parameters. So we really want to scale up this service to remain at the community level. So that only those who require to go upstream can able to do that. And this means we will have to have some hard conversation with people that probably are aligning to those parameters. But it's more like a trade-off. You either accept the burden of influx of patients to the facility and get poor service, or allow these professional cadre who are dedicated to do what we can do ourselves at home, right? We need to see and learn from our colleague. Rwanda, for example, I'm going to insist. Ethiopia, for example. This country does not have full capacity of the requirement of human capital for health. It is a CHV that has helped them to change drastically their indicator, right? And now when we want to see, when I went to Rwanda and Ghana, I literally watched CHV taking care of nutrition issue, taking care of malaria, taking care of family planning. You know, it's training. You know, when you train somebody, and most importantly, they are coming from exact neighbor. So there is a better chance for the person in the neighborhood to go to the next door neighbor to get cared for. Yeah? But if that's not enough, there is always a woman somewhere in Zanzibar who is pregnant, and she's probably got 2,000 shillings in the morning. That woman has to make a hard decision. Do I use my money to get a loaf of bread, or do I use it to take a bus to the clinic, right? If CHV is within the proximity, yeah, will it be convincing that it can be done without her spending any money? Does it make any sense? So we need to make her choice, and as we venture into a fully fledged health system, maybe by then we can able to say, nah, this can be done by that. But right now, we've seen all these parameters of health are not in the right direction, and one of the reasons should be pointed at human capital for health. And this cadre is a right match to able to make sure those interventions. So Zanzibar, we are planning to go full scale in terms of malaria, nutrition, NCD, and other parameters that we think they may be able to do with full training. And I think I've touched that, but quickly, when it comes to budget and timeline, yes, we have budgeted and we have submitted to USAID for support, and we are planning to go through a roadmap of 4 years before government can fully adopt CHV into the part of the health system, which will definitely be paid. So we encourage the donor, partner, whoever is interested to really embark on us to make sure we sustain and retain this important cadre so that we can able to meet our government aspiration and vision to ensure we leave no one behind when it comes to healthcare. Thank you very much.
Let's put our hands together again for the moderator and her wonderful, insightful panel. They did a great job. Wapongeze sana pamoja na CHV. Asanteni sana. We ate 10 minutes into the break, so you're going to have a 20-minute break. And for Mikumi Hall, we welcome you back if you want to attend the USAID session at 11 a.m. So grab your coffee, go take your tea, and look into your agenda. We resume at 11 a.m. sharp, and for this Mikumi Hall, it is the USAID Forum. Asanteni sana. Karibuni tena. Good morning, ladies and gentlemen. If you're coming for the USAID session that is coming up next at 11 a.m., you are in the right place. It's still break time, but we're really glad that you're able to make here much, much earlier. So if you're coming to the USAID Forum in Mikumi Hall, as your agenda shows, I want to confirm to you that you are in the right place. Mic test. Good morning. Habari za asubuhi mabibi na wawana. Good morning ladies and gentlemen. We're just about to start with the session. We're going to be on time for the USAID session on sustainability financing Tanzania's health sector on the path to UHC. Right on the dot, I will hand it over to the moderator who will then call her panel on the floor. So 1 more minute to go. Okay, we're ready to go? Over to you, moderator.
Habari za asubuhi. I'd like to welcome our esteemed panelists to join us up here. You're welcome. Habari za asubuhi na karibu kwenye jukwaa letu la ugharamiaji endelevu wa huduma za afya. Ninaitwa Elise Lang, mimi ni mshauri wa mifumo ya afya kutoka USAID. Nina furaha sana kuwa hapa leo na ninatarajia majadala mzuri. Bado najifunza Kiswahili, naomba nibadilishe lugha kwa Kiingereza sasa. Asante. Welcome everyone to our session on sustainable financing for health. Government of Tanzania representatives, development partners, civil society, faith-based organizations, private sector. Welcome everyone. I'd like to introduce our esteemed presenters and panelists for today. From the Ministry of Health, Lusajo Ndagile, Assistant Director of Policy and Planning. From Polora, Dr. Ntuli Pagolongwe, Director of Health, Social Welfare and Nutrition. From WHO, Max Mapunda, Health Economist. From USAID, Godfrey Nyombe, our health systems team lead. From P4H, Cookie Tarimo, health financing advisor and P4H control focal person. And from the World Bank, Miriam Ali, senior economist. So to get going, we are going to start with a presentation from Mr. Max Bapunda to set the stage for us on sustainable financing for UHC. Max, you're welcome.
Thank you very much. As you have correctly introduced me, I'm Max Mapunda from WHO Country Office. For many of you, I think you know me as a person who have been working in this in the health sector, and in particular health financing for quite some time. Now, I was requested by the organizers to start these discussions. I know it will be very lively and very interesting, and I look forward also to learn more from you than actually what you will get from me. The next slide. Yes. When we talk about sustainable health financing, we would actually like to add another word there, not only sustainable, but fair. And in my last slide, I will talk about fairness and what it means to be fair. Now, what is sustainable health financing? This can be described as a system that meets the health needs of present without compromising the health of the future generation. Now, where did this concept start? I think we all know the idea was long, even before 2010, during the World Health Report, but it became very prominent in 2010, and the concept of universal health coverage. This approach combines normative goals that are embedded in the concept of universal health coverage, as I've said, and as you know, the universal health coverage has 3 dimensions, the famous triangle, which we know. But today we are going to discuss one dimension, which is financing, and because of its effect on the access of health services. So before we embark on the subject itself, I think we need to gather some facts regarding Tanzania. And I'm sorry, I'll be using a report of 2014, 16, 2017, 18 national health accounts. I'm aware this report has been updated. Ministry of Health has information, but as far as it has not yet been released, I cannot share that information now. So I will use the information which is available and which most of us have. Next. Now, first when we talk sustainable financing, the first thing is the financing itself, is it there? Because you cannot talk sustain while it is zero. As we can see, the financing is there, and in this first figure, we are showing the shares, not figures, the shares. In terms of shares in Tanzania, during this period which we are talking about, we see domestic financing growing from 59 to 68%, foreign going down, a little bit going down. But in totality, we see an increase in funding. Now, this is important in terms of when we talk about public finance and donor fundings. We consider this to be public financing. And for universal health coverage, the most important financing, which can be very helpful, is public funding than private funding. So it is important to note the increasing share of public funding in the health sector. Now, if we go into the share slowly, we find that government also share has increased from 39 to 45. We also see health insurance increasing. Out of pocket, we see it decreasing. And donor funding is also not increasing, it's actually reducing. So increasingly, tax financing becomes dominant. And that is important. Next slide. Now, if we look on the absolute numbers, the figures, because the shares sometimes doesn't reflect the amount. So in terms of the amount, we also note domestic funding increased between the years under question by 58%. Foreign has increased by 8%, although we notice that the share was actually declining. But in terms of the amount, it has increased by 8%. But more important, tax-based financing has increased by 114%. Now, some people would say, but we are looking on public expenditure reviews, and we see the proportion of the government budget to the health is stagnant or is even going down. But here we are talking about the amount of money, nominal terms, it has increased. Health insurance as well is increasing, and out of pocket, we see that it's going down, but it is still at a very, very high level, because as the figures shows us, it's around 22-25% being out of pocket. Donor funding also has increased to reflect the one which I presented before. Next slide. Now, as a share of GDP, for almost 3, 4, 5 consecutive years, it has been around 4 and 5%. According to the literature, it tells if the share is 50 and above, there are some elements of equity in that health systems. So these figures are giving some bright future. Now, the share of government health spending in total spending, it has increased by 10%. So these are some of the selected indicators. Next slide. Next slide, please. Now, unfortunately, in terms of disbursement, the increase, as I've already mentioned before, but in terms of disbursement for government budget, we note that whatever is being approved is not disbursed 100%. For the years which we took the budget speeches, we can see that it was actually disbursed by 53-57%. But we also notice, as I've said before, the declining out-of-pocket expenditure. These are some good indicators towards universal health coverage. Can we move to next slide? Now, the observation which we see, first, there is still existing gap in financing. The report shows us that per capita spending on health was $42 and $45 for the years which I have quoted there. Now, the recommendation which we get from various institutions, and I think these recommendations started with the World Bank report, then WHO report, macroeconomic report for WHO, then high level. Those recommends the figure to be around 60 to 80. So 45 US dollars is a financing gap, is a gap. So that one we need actually to note as we were talking about fair and sustainable financing. But we are seeing continuously public funding increases. These are shown by the reports of the National Health Accounts, as I've cited. And even in those reports which Lusajo the figures which he has very recently, which I know, there are increases in public spending for health. So it's good. But another observation is that there is a draft health financing strategy which outlines a path in investing on health financing to achieve universal health coverage. This strategy was 2016 to 2026. It's almost coming towards its end, but it has not been approved. It is still draft. But some of the measures have been implemented, and I think you are all aware of the draft Universal Health Insurance Bill, which was tabled to the Parliament. These are attempts to implement some of the strategies which were outlined in that strategy. So a path towards universal health coverage in using health financing is there. It has some weaknesses which needs actually to be addressed, but at least the route towards universal health coverage through that dimensions of health financing is there. Next slide. Now, what actions do we need to do? One is to advocate for more public funds. And these public funds, they could be taxation, as we have said that when we look public expenditure reviews, the share of health is still low. But the commitment of the government we see, and I think the recommended share of 15%, that was actually to make government more committed to health. But if you put those shares to all sectors, you are in trouble. But what is requested there is government commitment. Then the other thing is actually to look on the ongoing actions towards universal health insurance. And we must commend actually the government for the change which they made. Originally, they had proposed some different pools, but I think later they changed the course and to have one pool. And we emphasize on one pool because the insurance needs to address the needs of the people irrespective of the payment. So one pool is much more preferable than actually having a multiple pool. Say you have a pool of community health fund, a pool of national health insurance fund, a pool of optional members. I think these pools will not actually meet the universal health coverage as we are looking forward. Then strengthen health budgeting, execution, planning, monitoring, in short, public financial management. You will recall that I gave figures of what was approved and what was disbursed. If disbursement does not actually go to what was approved, then you have interruptions in funding the healthcare. So that one needs actually to be emphasized. The other thing is to carry assessment. You know, when we talk about financing, sometimes when people, they put themselves only in revenue raising, that is health insurance. But financing is much more broader than that. So there are functions which are to do with the health financing, and these are revenue raising as one of which we normally talk about. But there are also issues of pooling, as I've said, purchasing, benefit design, and rationing. Constantly, country needs to make an assessment to the functions, these functions of health financing, to see where is the problem, where you can rectify, and then it will help you to move forward with the idea of universal health coverage. Next slide. Last but not least, I talked about fairness, and this is very key, that the health financing system, which we think is ideal for universal health coverage, is that one which allows individuals to access health services according to their need and not according to their ability to pay. I thank you. Next slide. I thank you very much for this. I hope I have generated discussions which will be lively. Thank you, Alice.
Thank you very much, Max, for that overview. I'd like to invite Lusajo Indagile to present the vision for the Ministry of Health.
My name is Lusajo Indagile, Minister of Health. I think in my concept of healthcare financing, so for me, I can just explain where are we coming from and where are we now. If you go back 60 years back, the healthcare financing in Tanzania, if compared to now, they have been changed. Around the 60s, there was talking about the free service to the society. And later we come 90s, we introduced the cost sharing, and then we include the issue of wages for those who cannot access this. Coming to 2000, early 2000s, then we came with the idea of payment. We consider the issue of prepayment. So if you consider all those errors, the motive was to strengthen the provision of health service from cost sharing up to service. So that's why today we are talking about the bills. In the 2015, the government started to think, especially on the concept of pulling the resource together. What are the best mechanisms to collect all the resource? So we think out now, at least we need to have the mandatory health insurance, whereby most of the whole population should be covered with the health insurance. And this was based into the study which conducted from 1994, especially when we were introducing CHF, and then the other healthcare financing study taking place in 2010 up to 2015 currently. They see the only mechanism of supporting health service is to have sustainable financing. So that's why now the government is in the process of developing the bills. We are aware it was last year whereby the bills was tabled to the parliament, there are a number of issues raised. But the aim was to make sure people they will access the service without financial hardship, because we know most of the population they suffer from economic hardship. As I was speaking, the population covered with insurance, we are talking about only 15%. So if we talk about 15%, comparison out of 100, you can see there are about 85% are not covered with insurance. And we are experiencing the era of whereby the number of disease, and then in people they want to access the service, they don't have the resource. So I'm trying to explain where are we coming from and where are we now and what are the direction of the government. That's why we are here, making sure that we are going to implement the universal coverage. As you can see, that some investment have been taking place with the government. The aim is to reduce the fragmentation of the resource. Max Bapunda mentioned we have challenge of out-of-pocket.
So the only mechanism is to having mandatory health insurance. We have national health insurance, we have CHF for the informal sector, we have private insurance. All those are trying to address the issue of sustainability financing of the healthcare service. Thank you.
Thank you very much, Usaja. So we're going to continue on to our panel discussion. We want to talk about, what is being done to support domestic financing initiatives for health in Tanzania. And as we heard from Lusajo, the government of Tanzania has a goal of reaching universal health coverage and really ensuring that every citizen has access to quality health care, but there's still a long way to go. So I'd like to ask our esteemed panelists about the current initiatives and opportunities for sustainable financing, including but not limited to domestic resource mobilization and improved efficiency, such as public financial management reforms. So I'd like to start off with Max Mapunda from WHO to ask about, given where Tanzania is now on its path to universal health coverage, what do you see as the main challenges and opportunities for improving access to healthcare for all?
Thank you very much. I think there are more opportunities. And over recently, you have noticed an expansion of primary health care facilities. The government is expanding primary health care facilities. These are opportunities to increase the access in terms of services. But the challenge which is clear is the functional accessibility of these facilities. That these facilities, sometimes they lack resources to be fully functional, no inputs to run them. And this is a challenge. And I think government, when it's making all these efforts, is trying to make this functional. Because if they are not functional, then achieving universal health coverage is a big challenge. Then, remember when I was talking about the per capita spending, which is very far below the recommended levels. But I think for some of us who have background in economics, we know that you cannot satisfy everything. You cannot get everything. So with that little amount of money, I think government needs to look more on issues of efficiency. Unfortunately, I did not have access to some of these studies of efficiency. I would have shown. But we know from literature, investing in primary health care is much more efficient than actually tertiary health services. So these are some of the challenges which actually government needs to look at. And efficiencies are looked actually on two dimensions. They are allocative and technical efficiency. One good thing with this government, they made a lot of studies and trials. And some of you will remember Tanzania Essential Health Package program, which was actually encouraging, with the little money you have, to choose the most cost-effective interventions. So these are the areas which government can think about when it talks about improving efficiencies. Last but not least, to give time to my colleagues who are also contributing, it's the issue of fragmentation. I talked about pools. There are so many pools right now. We have government pool, we have national health insurance pool, we have community health insurance. So these pools, first they are disaggregating people not to achieve services according to their needs. So these are some of the challenges actually which we need to address. And I know government is, the process towards the establishing universal health insurance is actually towards that direction. So we would encourage government to move towards that direction. Thank you very much.
Thank you, Max. So I know Lusajo and Dr. Julia are probably eager to respond to those questions. But before we get to that, I'd like to ask Miriam from the World Bank if she could tell us a bit more about how the World Bank is supporting Tanzania to improve access to health services for poor and vulnerable populations, recommendations you have for improving equity in health financing.
Hello. Good morning, good afternoon. I think it's good afternoon. Thank you so much for inviting me to participate in this session. And we agreed because the session aligns very well with the World Bank twin goals of reduction of poverty and shared prosperity. When you talk about access to the most vulnerable, you're talking about the people who we care most, whom the bank is established for them. So we really, the topic aligns very well with our objective. Now coming to what bank is doing, bank, as we all know, is a knowledge bank and is also financing bank. So in Tanzania, we are doing the same. We are supporting the government together with the other stakeholders, developing products, knowledge, studies. We have been supporting government in various studies, health financing. Recently, we released a report together with the government on pharmaceutical production. And I'm really glad that we are going to, it's really moving up and implementation is coming. We have been supporting government in pandemic preparedness studies. And most of the studies, to be frank, have been informing policy, our policies. For example, when we are starting DHFF, when we are starting, we are doing the UHI, we are starting the rally because it's almost 10 years. A lot of studies which have been supported and they have been informing the government and the other stakeholders. So that is one area. Second area, bank is also financing, is giving finance, and the comparative advantage of the bank financing is that first, it is disbursed, spent, designed through government systems. The bank uses government systems to deliver our support. In Tanzania, over many decades, I think 2 or 3 decades, bank has been supporting, focusing on primary health care. We have been supporting primary health care because that is the most cost-effective, most efficient interventions that can bring forth big outcomes. In the previous project, the last but one, the last one, we supported government and we had measurable and really promising results. One of the things we are happy and proud is we actually bank started the initiatives of renovation and construction of PHC facilities. We started with 100 facilities and government themselves did it. And one of the things we are happy is the capacity built within the government to design, to supervise, to also make sure that these things are functional. We are saying that because through this initiative, government has now a guideline of how you can do it. That's how a bank works. We are happy because not only that they did construct, but also services are delivered. In these facilities, C-sections have started about, in our last report, it was 100,000 people have received services. The other thing is on the performance Our bank has moved towards performance financing. We used to support, we used an instrument called IPF, investment financing, but now we have moved to performance programs for results, whereby we agree with the government. And this is really encouraging because it builds the capacity of the government to supervise, to plan, to implement, and supervise themselves before it comes to the bank. And this, when we talk about efficiency, when Dr. Mapunda was talking about input, output, the technical efficiency, and even allocative efficiency, I think these are the things which put the government into driver's seat to implement, because they have to earn money, they have to produce results, they have to put systems like internal auditor general, the one who is now verifying within government systems. Bank is just outside supporting together with the other partners. We are happy through, again, bank support, Health Basket Fund, we introduced allocation formula, which is performance again. Equity-based, part one, but also performance, to make sure that those who perform, those who really deliver services, they get the money. Because some facilities, it's not by design, it's not by, but maybe it's not that they are not working hard. It's just by design. Maybe the way they are located, they don't have enough patients. Why do you give them equal amounts? So we have introduced that, and we believe that government is happy and proud. That's why they've introduced it in the DHFF, and they are now moving forward to review formulas. But we are happy that performance elements are in there. Okay. Oh, it was wrong to look at you. I was supposed to look that side. So with the bank, those are the things we have done before. But now, currently, we have a very new project, which started this July. This project, it is also still focused on PHC, 5 years project. But one thing which we think is new in this project, we are focusing on bridging the gap from the PHC to secondary care. Because most of our services were focusing on PHC, but we realized, especially for women whom we care most, when they are referred to district and regional hospitals, the capacity is not there to receive them. So that is one area that we have introduced, but also to scale up government initiatives. Bank is good at that. We are now going to work with government to make sure that we implement an emergency transport system, but also most cost-effective intervention. We are going to work together with the government, but in a performance-based approach to finance community health services. We are going to use government systems to pay CHWs, whom are really very crucial in the service delivery. They are most cost-effective persons who detect early diseases, help people to attend and access preventive services. We all know that. So that is the area we are now going to support. Thank you.
Thank you, Miriam. I'm going to pass it over to Lustajo. You spoke about the government's vision and work towards universal health coverage. I wonder if you could speak more about the main challenges to funding quality healthcare in Tanzania and the current opportunities, and perhaps speaking to some of the points that we've heard from Max and Miriam about efficiency, fragmentation, community health workers, performance-based financing, etc.
Thank you, moderator, for this opportunity. So for the case of the challenge, is it? Challenge and what are the opportunity? I think one of the challenge, fragmentation of the resource. And this can be, we not all talk about for the health insurance, but also in the mechanism we use to fund the health sector. For instance, you can see most of the resources are allocated through off budget. And some of them, they are channeled through the government system. So sometimes it became challenge how to track. We know we are doing stats, we have some of the system, but it becomes difficult to know how much you have because some of the funds are going direct to the projects, so it takes time to get the information. So those is one of the challenges we experience. We have the system, DHFF, and to improve financial management. I think if we comply with the government system, the issue of sustainability will be addressed. I remember we did one of the start with the support of partner, but the data show there are a lot of the resource go to the project instead of coming direct to the health sector. Because as a sector, as a gap, we have the priority. So sometimes we compete within our priority. We allocate the funds from one of the areas and you find the other partners support those areas. So why can't we sit together? No, but maybe let us harmonize those mechanisms. Apart from that, another challenge I already mentioned before, the issue of out-of-pocket. It is a decrease, but it's not at a reasonable, because at least we need to reduce the out-of-pocket. So in terms of what are the opportunities, I can just list some of them. Number one, government commitment. That's why here we are talking about the bills. The government is high committed. We are going to implement the universal health coverage by finalizing that plan, because we know most of the people, they are not covered with insurance. Apart from one, we have the improved financial management. Now we channel the funds through DHFF to the facility, especially basket funds, but we are seeking even other resources should be channeled the same to give autonomy to the facility. Another, in terms of infrastructure, we are doing well. I don't need to mention, but all of us, we know there are a number of facilities from primary levels up to the national level. Almost, we have strengthened the regional referral hospital, national hospital, zone hospital, even to primary level, by equipping them and even providing human resource for health. We know we have shortage of human resource for health, but at least we are trying. That's why we are coming the program community health work, at least to reduce the existing gap of the health sector. Apart from that, also we have the issue of quality of service. We are trying a lot. There are a number of improvements have been done. Current at the regional level, the focus is at least to have the specialized service where previous could not avail those services. We just get from zone hospital up to national level. But now even the regional hospital of the super specialized service, sometimes even at the district level, we have some of specialized service there. Another, when you talk about the health commodity, a lot have been invested. If you go through the budget allocation, especially for this commodity, for the consecutive more than 5 years, they've been increasing. Today we are talking about, for essential commodity, more than 200 billion allocated for this commodity. Those to ensure at least to improve the quality of service so that people can access this commodity whenever they go to the facility. In terms of information technology, we all know we are now talking about telemedicine as a mechanism to address the shortage of human resource for health, but also to improve the use of the system. Nowadays we are trying to connect the national hospital with the regional referral hospital with telemedicine. Nowadays you can get the service, you're in Mbeya, you're in Tanga, wherever. You can contact the people from Muhimbili, from Moi, do consultation, and when need arises with the referral, then you can be sent to the national level. but at least we are trying to solve the issue of human resource files, but also to improve the quality of service. Another area, in terms of preventive service, a lot have been done. If you could see the coverage for vaccines is more than 90, according to the stats we have. Even the area of mother and child, a lot have been done. We have CMOC and others facility. In terms of, so those are the commitments as well for the government toward the universal health coverage. But the most important things in this forum, I think all us together, we need to see how to comply with the government system in financing the health sector. If we concentrate on looking at least people they need for health insurance, where we allocate resource at the different mechanism, I think the issue of sustainability will be a challenge. So I think all of us together need to see what can we do. We are talking about the health coverage. Do we our resource following the government system? If not, what can we do? Thank you.
Sajo. So, Dr. Ntuli, could you tell us about the work that POLRAG is leading on improving allocative efficiency in service delivery and public financial management? What more is needed?
Thank you very much. Thank you very much. I think it's been spearheading the issue around the efficient public financial management. And we have had a number of reforms, but the notable one is of 2017 when we did introduce the Directors Facility Financing. And through that arrangement, what we have seen, there's a tremendous improvement in terms of our quality of services rendered to the people. Because we did the before-after study to compare a number of our indicators before the introduction and after the introduction. But what we have seen is quite very clear that after the introduction of the Directed Facility Financing, there was increasing the efficient use of resources, but at the same time, we also witnessed the improving number of maternal newborn indicators, the supply chain management indicators, also the financing indicators. So this is one of a very important initiative as far as the allocative efficiency is concerned. But apart from that, we worked with the World Bank to improve the resource allocation formula so that to make sure that whatever resources which we are dispersing to the lower facility level should be able to take into consideration the issue of equity. Initially, there were some of the things which were not taken into the formula, but later we had to introduce, including the issue relating to hard-to-reach areas. We have some of the districts in the country with many islands, including the Ukerewe with more than 38 islands. So we had to separate these council to the other councils to make sure that we allocate the resources effectively. However, I must admit that one of the challenges which we have experienced is how do we take care the implementing partners. Usajo said, part of it, we have two main arrangements for dispersing resources to the lower level. We use the exchequer system, and also we use the direct-to-project funding. But we have some other partners who are swimming in between. So they are neither on the exchequer system nor on the project direct funding mechanism. And this is the tricky part. We need to get hold of these partners to be able to track their resources, to know how much do they contribute to our primary healthcare system in the country. So there's a lot of duplication. You might find there are 3 or 4 partners doing the same thing with the same amount of resources. So compliance to the government system is quite key if we were to sustain the healthcare financing. Otherwise, if there are people who want to be complying, then it will be very difficult. We have had a number of systems now. We have the financial tracking system, which is called FAS, Facility Financial Accounting and Reporting System. It's working pretty well, but we need all the people to be in that system, because with that one, that system, you can have a real-time information of more than 6,500 primary health care facilities in the country. But we need everyone to be on board for us to be able to track all the resources which are for the health sector. That's one. But the other thing is we have to make sure now, whatever penny we are putting for the health sector or primary health care should translate into quality. But we have seen a number of quality indicators which we chose. We've been following them through for the past 5 years, and they're working pretty well. So we need to keep on putting money for that. And I must say that primary health care is a strategic area for us to change everything. Everything is happening at the primary health care. So whatever investment we'll be doing, let us go to the primary health care. With secondary, tertiary, they are far better as compared to that level. We need to have electronic system. We need to digitize the primary health care. So I'm going to use this platform to call for partners to work with the President's Office, regional government, to digitize the primary health care, to digitalize the primary health care. In so doing, then we shall be very sure whatever money which goes down, that we have some return on investment. So this is what I wanted to contribute, but again, maybe to add on what Mariam said, we are slowly moving from input-based financing to performance-based financing. With World Bank, we have divided our resources into the base tranche, and then we have the performance tranches. And it has motivated our facilities and our colleagues, the frontline workers, to really now focus into putting much of the effort to improve the primary health care. So I think that should be the move. Slowly, we should move from the input-based to the performance-based. So I'll stop there, but otherwise, we need support from different stakeholders to work with us to make sure that the primary health care are well financed, and whatever resources which are directed to the primary health care should be effectively used. I know with the system which we have, we need to optimize them so that they can efficiently give us the good results. Thank you.
Great, thank you, Dr. Ntuli. So that's a good segue to our next main question. So as we think about development, one of the goals is really to gradually shift priorities and adjust resources to support country priorities and government priorities, and for the government to really take full ownership and stewardship of all of the activities in the country and the health sector response. And so as the Tanzanian economy grows and development partner funding stagnates and declines, what progress have we made towards streamlining development partner funding and managed initiatives to the government and local organizations, and what can we really learn from these experiences? So I'd like to pass it to a colleague, Godfrey Nyombe, to talk a little bit about what USAID has been doing in health system strengthening and about institutionalizing systems in support of government stewardship.
Good morning. It's still good morning, few minutes to morning. Thank you for at least for the question and the distinguished panelists here. Just to really appreciate the stage that has been put down by my former speakers here, and really saying about what USAID focus on the areas of sustainable financing. USAID Health Systems strengthening strategy really focused around three main priorities: quality, equity, and resource optimization. But for this case, I think I'll focus more on the resource optimization. This is where I think most of the conversation here has been also really focusing around how can we have more efficiencies? How can we support the government to have more efficiencies around all the resources that are pulled out into the health sector? And within this, I think Max has also mentioned earlier, one of the priority area of where we can have a great win is through the execution, monitoring, and tracking of resources. And I think that's where the PFM work of USAID really is really focused on. A lot of the work that we have worked with the government, Ministry of Health, and PORAC, together with the World Bank as well, has really focused on strengthening the public financial management systems. And that has been, I think, a critical story, and actually adding to what Ntuli was mentioning earlier, that we wanted to create more confidence to the public financial management system. So to allow the challenge that I think he just mentioned on donor-funded and other donors to contribute through the government system, using the confidence of the PFM systems that are strengthened. And that's the fact why we started, I think, around 2017-16 to support the government through the planning processes, from planning and reporting systems. The AMREF system came into action, and now it's scaling beyond health, and everyone is using the automated system within the government systems. And we are happy some of our partners are already using those systems to actually put their interventions within the AMREF system. But also looking around now, the DHFF money going down, we went further into the PFM system, supporting the government as well to the FAS, the Facility Financial System, very government-owned, and actually at the moment, we're supporting the government to move it further to the village level, to the community level, where there's some community interventions that are happening there. All of these add up together to what I think we really aim to have, all resources tracked and be able to really be efficient in how we are optimizing the resources that are there. And a little bit touching into the human resources, because it's a financial component of human resources as well. USAID is also trying to use the same aspect of optimization of resources and efficiencies to try to help the government to optimize. We may not have all the human resources that are needed right now. We're at 65% of shortage. We may not get there, but whatever resources that the government may have, whatever healthcare workers that the government may have, including our projects and activities that are working on the ground, how can we optimize and make sure that we're allocating workers where they're mostly needed and where we can really see the impact of service delivery? So I think that, to summarize, is the area where we're really looking forward to continue working, creating more efficiencies, creating more optimization, and be able to strengthen the existing systems in the PFM, and that's how we can really create the good ground for universal health insurance when it's ready. Thank you.
Thank you, Godfrey. So I'd like to continue on to ask Miriam if she could tell us a little bit about how, the fact that you spoke before that the resources move through the government system. What have you learned from this experience, and what would be your call to their development partners?
Thank you so much. Just quickly, what we have learned so far, one thing is we have great counterparts. We have great counterparts. When I say counterparts, I mean government colleagues, as officials. They are ready to cooperate, to work together towards agreed objectives. These reforms we are talking about, they are not simple. They are really, you need to take risk as a manager in the government. But these people we have been working with, PORAG, Ministry of Health, Ministry of Finance to start with, because they are the ones who always give the green light. They are very good and willing and ready to work with us. And that's really a positive, because without leadership from their side, it's very difficult. The other thing which we have learned is that since these reforms are critical and complex sometimes, it's easy when work and use the reform. You know, should I be more specific here, Geoffrey? Will you be offended? You know, you can, for example, when you develop a system as good as FAS, and you don't use your resources, yeah, sometimes it gives some question mark to other partners or even to government. But when you introduce a reform which is complex, that was just an example. But there are many other reforms which are very complex and sometimes risky. But if you use your resources to implement that reform, it gives them confidence that nobody wants a loss. So if you are ready and willing to use that to introduce the reform using your money, it means you are confident with what you are introducing. Also, being a bank with many countries, bringing experience from elsewhere has been very useful, and the government of Tanzania has been very receptive to learn and to adapt. The other thing is capacity. When you use government system, you build capacity that needs, I don't need to explain that much, but capacity of institutions first, second, individuals. When we talk about institutions, I remember when we started the first project, everybody was cautious to use internal auditor general to verify, you know, conflict of interest, you know their capacity, everything. But we said, no, this is what the government has. We are going to equip, we are going to capacitate them. And now you can't believe it, almost everybody wants to use IAG. So capacity, and these are lasting institutions. I underline lasting. Bank project will go, Mariam will go, but IAG will remain with that capacity to help the government. Need not speak. I don't want to talk about the other side. What is the message I give to others? I think that is beyond my pay grade. But let me give my experience working with the government. And it has been a pleasure, to be frank. Thank you.
Thank you, Miriam. So I want to ask Lusajo and Dr. Ntuli to reflect on what we've heard from Miriam and Godfrey about the initiatives for institutionalization and capacity development, and really shifting as much of the resources as well as the ownership, really full ownership of the systems to the government. What lessons are we taking from that, and what more do we need to do?
Governments needs partnership, meaningful partnership, and we have enjoyed with the World Bank, with the USAID and different partners. Some they assign the expertise or the experts to our department to work with us, of course with the World Health Organization. So we have enjoyed in that area. But importantly, I think is the knowledge transfer now after the assignment. When the teams, especially the indigenous, when they continue with what they've been capacitated with, this is something which we usually value a lot. But adding to what Mariam has said, when it comes to the reforms, there are two types of reforms. We have the minor reforms, where you do just some small adjustment to a program or something like that. But with major reforms, really, that's a huge risk when you go into that. So you need different stakeholders to work with you, to support you. One of the major reforms, I must say, it was the direct facility financing, or the FAS. Most of the people, they were very much skeptical. They were not sure whether the money would be safe. And when we started with the measles rubella campaign, money being dispersed by WHO by using that arrangement, so everyone was happy that, oh, the system is working. But when we started, it was not easy. It was not easy at all. That's why I'm insisting that if we are to move forward to have sustainable financing, everyone has to comply. That should be the first step. But secondly, is to make sure that whatever we are doing, we should embed it with an implementation research. We need to learn scientifically whether the initiative is working or it doesn't work. So research cannot be left behind. It has to be part and parcel of our every undertaking so that we can scientifically learn whether an initiative is working or it doesn't work. Then the last thing I think, which is most important, is to always come up with another set of reform. Reform is an ongoing process. You cannot do it once and then you stop. You have to do it on a regular basis so that you can improve. And we have learned from the 1994 health sector reform, and then 1998, and other ongoing reforms. You usually build from the previous ones. So I think that should be something every one of us should take back home, that reform is something that has to continue all the time.
Okay. I think most of them Dr. Antoli mentioned. So maybe I can just say some few things basically on question raised. Number one, we appreciate the working with the partners, because in any development, teamwork is required. As a government, we also need to work with the partner. As we are aware that here we are discussing the issue of healthcare financing, we know now the direction is going to have universal health coverage. Their resources are going to be required to implement. So it's the higher time for the partner to see how the best can support the government toward the implementation of universal health coverage. We appreciate the number of partners who continue supporting, technical support, and even financial. So I think maybe let us focus on those areas to see how the best we can implement the universal health coverage. For instance, now we are talking about it's mandatory. So how we are going to finance the poor? We are talking about 26% of the Tanzania, they cannot afford to cover for themselves the health insurance. So who can finance? We know the government finance, but also it's the higher time for the partner to see how they can support the government. Because if we just insisting mandatory insurance and you know people, they don't have access or they don't have resource to pay. So I think we need to discuss together and see how the best we can support the government. Not only that, we know approve the bill is one thing, but the implementation is another things. The number of institution arrangements should be taken place. Also, we need to support those areas. Capacity to train. Dr. Antoli mentioned about the research. That's very important things. These are going to be new, the first things to be implemented. So a number of research are needed in relation to our country situation or our environment. We know the other countries have been implementing risk coverage, the Rwanda's, other countries, but how best approach can be applied to our country in order to make it sustainable, especially when we focus to supporting the society, especially the marginalized society. So for me, I think that the most important things, if we get the answer for those areas on how to support, I think the journey won't be difficult. So thank you.
Thank you, Lusajo. Thank you, Dr. Njuli. So now I'd like to pass it to my colleague from P4H, Kuki. Kuki, you've heard from all of the panelists about reflections on domestic resource mobilization, public financial management, as well as opportunities and initiatives to really improve institutionalization of certain systems. Could you tell us, given where your work with the government, both on mainland and Zanzibar, now on this path to UHC, how do you think that the government of Tanzania and development partners can best contribute to improving domestic resource mobilization?
Thank you very much. I'd like by saying that the good thing is in Tanzania, we have actually the framework, which is the instrument under the Ministry of Finance, which actually highlighted how should development partners and government work together to achieve a common goal. I think that framework is called Donor Coordination Framework under the Ministry of Finance. And the good thing in Ministry of Health, we have this what is called SWAP, sector-wide approach, whereby we have these different technical working group, whereby expertise from development partners and government sit together and discuss different health issues and coming up with a common understanding on how to solve those problems. And I think over the recent year, this mechanism, especially this technical working group, have not been working effectively and efficiently. And I think now to strengthen this coordination between development partners and government, I think now we should ensure that this technical working group working effectively and efficiently and in terms of discussing and creating this debate. The second thing maybe which I can highlight is the point of sustain and increasing domestic resources for the health sector. I think inside of development partners and the government, they should work on creating more smart advocacy to inform maybe the decision making, especially the Ministry of Finance, to understand the needs of health sector. So helping actually the side of the health sector to develop these evidence-based, as Tuli and Lusajo mentioned about research, evidence-based research to show the case that we need. Because you cannot go to Ministry of Finance saying, do I need these resources, and you don't have numbers. Of course, things are, you can see in health sector that we need this, but we need to have, we need to move to smart advocacy by having this evidence. And also showcase how efficiently we are using. Max Makunda talks about efficient utilization of resources that we have in health sector. So we together, government and development partners should work on showing the case how efficiently we are using these resources for the health sector to come up with a big outcome. I would like to stop there.
Thank you, Kuki. So that's all the questions for our panelists for now. Now it's your turn. So I welcome any questions from the audience. We'll take 3 to start. Okay, way in the back, I saw that hand first. Karibu.
My name is Gori from Soya. I'm a public health student, and I've been practicing public health for the past 40 years or so. So I've had a lot of time to look into this issue of sustainable financing. I've looked at 199 countries in the world. Only about maybe a dozen or so will be able to achieve UHC by 2030. For sure, we are not going to achieve it. And for us, it will take 40 years. When I go onto my drawing board, I try all scenarios. Why? Because stunting is 30%. And if you have stunting, it cuts across old ages up to 100 years. If you have stunting of 30%, it will constrict your workforce between 15 and 64 by 30%. So that one part in supports himself plus an additional 3 persons. If you go, we are stunted by 30% of all groups, so that one person supports 4, so that it will not be possible to have sustainable finance until you eradicate stunting, which is purely nutrition and prevention. So I think we should focus that one, in that direction, so that we have a workforce that will be in 30 years that can finance health, but not now, not for health insurance. It is not possible. Ask an economist. Secondly, donors finance problem. They do not finance solution. Solution must be inside. So we must have this to tell donors what they should finance, not what they want to finance. And if some countries, this is our policy, we have 207 policy. We do not have universal health coverage legislation under the policy. We do not have a research agenda for primary health care or for universal health coverage. So everybody is doing all the researches. So I think we need a policy, we need legislation, and we need to eradicate stunting. Thank you.
Thank you for that comment. In the back, please.
Hi everyone, my name is Joseph Mweshemi from FHI. Thank you so much for the presenter Mapunda and Dr. Ntuli for demonstrating the government willing for sustainable health financing. My question is on the preventative care and health promotion. To what extent are we investing in preventative care and health promotion programs to reduce the burden of preventable diseases and ultimately lowering the long-term health care costs? Or we are more fixated on health financing for the tertiary and primary health care? Just to know to what extent are we focusing on the preventative care and health promotion services? Thank you.
Thank you. My name is Rukaya Mahmoud. I think both questions will go to Mr. Lusajo and Dr. Ntuli. First, I would really like to know how the government financed, during the 1990s era, we had free medication. And what is it that bothers the government to conduct with the same thing? That, okay, the population has increased, okay, but we have the population full of business people and full of taxes. So what really makes the government fail to finance healthy? But second, you were talking about completing the process of UHC. I would really like to give my opinion. When you guys are completing this thing, you should really consider on giving the services per the need and not per the packages or the payments. Thank you.
Okay, thank you. At the end.
First. I want to take my mic. Thanks a lot, panelists. This was a very, very good discussion, and I must admit it's in the heart, my passion. And I'm saying that I think Dr. Ntuli is laughing because they know we've been having some coffee meeting to discuss how can we sustain health financing at the primary health care. So AMREF, with support of Irish Aid, I don't know whether there's Irish Aid here in the room, we started a project in Mwanza to demonstrate sustainable health financing for community health worker, community health system. And one of the outcomes that we were expected, or we were to showcase, was how can the community health worker continue to be paid beyond the program using the FAST and the direct health financing system, the DHFF. That has worked perfectly well in Misungwi, Kwimba, Itilima, and we wish that all donor funding, so we started with USAID, by the way. We have our USAID TB to also start using the same system to pay community health workers. So, of course, there are many challenges that people talk about regarding to the remotelessness of the health facility, the delays in approvals through the FAST system, which was challenging to that we can have this digitalize and have those approval being done at the level of at the facility level, instead of the medical officers moving around to seek approval. So the community health workers are paid. So we send funds directly to the community health workers' accounts, but it is approved through the FAST system. And the good thing is in Misungwi, and you can even go and check with the district executive director, they have promised to sustain almost 10 villages that they are ready to contribute beyond the end of our project to put money for continuing payment of their community health workers. So these are very good examples that we really should work together and see why not all donors and partners are willing to pay through the direct health financing system and not sending money through M-Pesa, etc., to their accounts. I think that system works very well. We are championing it very much, and we wish it to be scaled up throughout the country. And thank you so much.
Okay, thank you. So to our esteemed panelists, how would you like to start? Dr. Ntuli, would you, or Mike? Okay, Lusajo, the floor is yours.
Okay, thank you, members, for the question. I'm going to respond. The other, Dr. Ntul, will add. And number one, we talk the issue why the government does not offer free service as what has happened in 60 years. In economics, we know always the resources are scarce. And there is a competing demand. I like the way she mentioned about the population size. Might not be the reason, but might be a factor, because population 60 years up to now, it is increasing. But we need to see the issue of sustainability financing. That's why the government since the 60s, the number of reforms that have been taking place, from free service, we moved to cost sharing, we moved to waiver, and then we moved to health insurance, and now we are going to have the mandatory health insurance. So the aim is still the same, but we haven't changed the modality on how to finance. It's not only in health sector, but even in education sector. I remember those days, there was a free education. But now at university level, we are going to access the loan. So the important thing is to ensure the issue of sustainability of the service. That's why we are now focusing on to have the prepayment service. but also to create the issue of ownership, because if you contribute to something, you create ownership of it. But also cross-subsidization. We have the people with higher income, others low income. But also the pattern of disease has been changed. Disease for 60 years to date, there are a lot of changes. So I think that the main reason. Another, you talk about the issue preventive and the promotion. We agree, if you go to the start, most of the resource allocated in creative service, it is very true. But that does not mean the preventive promotion is not important. Still, it's very important. That's why the government or the sector advocates on the issue preventing disease such as NCD. There are a number of forums. Now we're encouraging people to do exercise. Even now, if you go to the government seat in Dodoma, the infrastructure have been considered on the people they can do exercise. We are not doing much a lot, but something is happening to promote the area promotion and the preventive service. Because at the end of the day, if we invest much on the preventives, we are sure even the budget for creative service will be reduced, because wanasema kinga ni bora kuliko tiba. So we agree, number of efforts have been ongoing. And that's why we insist people do exercise, diet, to consider the issue of diet. Yeah.
Thank you, Sandra.
Yeah.
We only have a couple of minutes left, so I want to make sure we have 1 minute for Dr. Ntuli and 1 minute for Mike's to respond.
Thank you very much.
Thank you.
Yeah, I think maybe to add on what you said, we follow the primary health care service provision framework, which we start with health promotion, then we go into protection. Now the WHO and American Society of Public Health, they have added the protection. It was not there before. We had just the preventive, but now we have the health promotion, protection, prevention. Then we go curative, then continue. With the new guidelines, much of the emphasis has been put into the health promotion. But I must admit that of all these components of the primary health care service provision framework, the health promotion, it has never been taken serious by people. Most of the people whom you see they're exercising, they already have the NCDs. You do your research. And this is a new finding from one of my colleagues in Kenya who conducted a study in that. That the people that will start now going into exercise, after being told that you are pre-diabetic, take care. Otherwise, so that is something everyone should take it. But looking into what Dr. Swai said, the government of Tanzania is seriously taking the nutrition issue into account. That's why Her Excellency Dr. Samia Suluhu Hassan signed the performance contract just for nutrition between herself and the regional commissioners. And that has cascaded up to the community level, just to try to highlight and to make the nutrition agenda visible. We are not doing well. Stunting at 30% is not good. We have 28% of anemia as a prevalence for women of childbearing age. We are not doing well. But I think that should not deter us from continuing with some other activities. We should continue investing in nutrition, but at the same time, investing into the health. That's why I'm happy that even our department is called the Department of Health, Nutrition, and Social Affairs Services, just to make nutrition visible. But the complexity of nutrition is much sectoral. It cannot be dealt with health alone. You need people from the water sector, agriculture, and what have you to work with you. And then the issue with regard to the 1990s, where we had to embark into the cost sharing and other things, that's a long history. And I would recommend you maybe to get a copy of the book which you have written it. We have written it extensively to explain what happened after independence, and even before independence. That will explain a lot. So I'll get you a soft copy. With what Dr. Moya said, I must commend AMREF Africa. They are working with us very, very, very close, and we have done so much with regard to the direct facility financing. With regard to the challenges which we are experiencing right now in Misungwi and some of the other districts in the Lake Zone, we have come up with a new solution now. It's going to be a digital one. And we have tried it with the M-Mama system. Because we had a similar challenge of getting the drivers, especially those who are owning the taxes. But with the new solution, we worked with the Minister of Health, the Minister of Finance, and the PRH. Now we are having the solution. So they can be paid via their mobile phones and also via their banks. So that will no longer be the challenge at all. And with regard to other things, on universal insurance, as my colleague said, we need partners to work with us. As soon as the bill passed in the Parliament or the House of Representatives, then we'll need you partners to work with us. We need to take off now from there. So the issue at hand is to make that bill pass, which we are quite very optimistic. But again, after that, financing for the poor, it means a lot, and that is what we call leaving no one behind.
Thank you. Well, we're over, but Max, if you want to give a few words.
Thank you. Thank you very much. For the student who doesn't graduate, Dr. Swai, though he was my teacher in public health. Dr. Swai, don't be pessimistic. We do monitor, WHO do monitor universal health coverage, and we produce indexes. And we find there is a relationship between income. And you know, the last when we produced these figures, it was in the Brown Bag meeting in WHO about 4 years ago. We were about 47%, while those countries at middle income levels, they were 70, 50. But mind you, by then we were a lower income country. But now we are lower middle income country. So that index might actually have gone up. So when we give up next figures, it will be different. And on top of the figures which I've produced here this morning, that it shows that the direction we are moving is the right direction. So don't be pessimistic, be optimistic. Thank you.
Maybe to add on what Mapunda said, so our current universal coverage service coverage indicator is 43%. So we moved from 38% in 2015.
Okay, last but not least, the reports which I presented this morning is national health accounts reports. Unfortunately, some of us, we don't contribute information to that report. We don't even read it. It's a very important report to make decisions on all health policies and health financing. Thank you.
Thank you. I'd like to thank everyone, our esteemed panelists, very much for participating. Thank you, audience, for your questions. This was wonderful. Thank you again for joining us. Sana.
Let us put our hands together once more time for the moderator and her strong panel, and for leading the session so ably. Asanteni sana.
Asanteni sana.
If you want to stay in Mikumi Hall, which was sold out, and we love you all for that, delegates, we had a sold out session. We would like to sell out the next session as well. So the next session will be on AMREF Forum, which begins right now. And the couple of minutes we've eaten into the forum, we'll take it a little bit into lunch. So thank you so much. The next session in Mikumi Hall, it's going to be the AMREF Health Forum, and you are welcome to stay. Karibuni sana. Thank you so much. If you are staying now, it means you are staying for the AMREF Health Africa Forum, and we are starting on time. Ladies and gentlemen, we're now into the AMREF Health Africa Forum. I will request you to take your seats because everything that we're doing now is eating into the next session. Karibuni sana, and I would like to call the attention of the moderator for the next session. The moderator for the AMREF Health Africa Forum, please, you're welcome on stage. Everyone, please, you are welcome to stay. We love it when Mikumi Hall is sold out, so please. All right, we are already in session. We are already in session for the AMREF Health Africa. The seconds are ticking away. We are chipping into their session. We welcome everybody to take their seats. Please. Everybody, please take your seats. We are already into the AMREF Health Africa, and the session is a successful engagement of community structures in public health emergency response. Ladies and gentlemen, one more minute. Session is already in session. And if you have forgotten your phone, please, I have it with me. Someone who has forgotten their phone, we are going to keep the phone with us. In the previous session, somebody forgot their phone and they came and recovered it. So we have a phone here. If you have forgotten your phone, please look out for me or one of the volunteers who are in blue t-shirts. Please, jamani, tunawashukuru sana session iliyopita. Tunaomba sasa tuwape nafasi the next session. Please. Please, please. If you can hear my sound, my voice, I know you can. Thank you so much. We would like to give space now for the next session. Asanteni sana. Because everything we are delaying is eating up into the next session. So thank you so very much. With that, I would like to hand it over to the moderator. Moderator, you're right here.
Yeah, thank you, Dr. Chaz. Good afternoon, everyone. Good afternoon, everyone. I hope the energy is not taken by the previous forum. So we need the energy similarly in this forum for the AMREF Forum. My name is Arita Mutayoba. I work at a capacity of Program Director for Disease Control and Prevention, and I'll be moderating this session for the next hour and so. In the session today, we are going to discuss about successful engagement of community structures in public health emergencies, the experiences through AMREF's work in collaboration with the Ministry of Health and PORAJ, together through the support of USCDC, Tanzania. And historically, we know that the Ministry of Health in Tanzania is implementing an electronic integrated disease surveillance and response system that is IDSR framework since 1997 in all of our regions as a requirement for the international health regulations that aims to improve the ability to manage public health emergencies and priority communicable and non-communicable diseases. AMREF Tanzania, through the support of the USCDC, collaborate with the Ministry of Health and the President's Office, PORAJ, to strengthen the surveillance system for early warning and rapid response of public health events of international concerns at the national and subnational levels. AMREF runs about 15 years experience in strengthening community-based surveillance, where it first pioneered the community-based disease surveillance pilot project in Mkuranga in 2009, whose lessons are really key and build up on what we are seeing today. From the pilot project, its lessons were taken up, and in 2015, through the CDC support, we were able to roll out the community-based surveillance intervention in Kilimanjaro and Arusha regions, where it paved a way for the event-based surveillance that we are currently implementing in over 15 regions in the country, and for the USCDC support in 18 regions overall. To date, through the USCDC support, AMREF is working with a network of over 1,400 community health workers to detect and report alerts immediately. And we are glad to say that we are working collaboratively with the Ministry of Health, where we have established the alert management desks in a number of regions, when the Ministry of Health rolled out the electronic EBS system. And to set the stage, I would like to welcome the first speaker who will set the stage. Before the panelists go forward, we have the Country Director for AMREF Tanzania, Dr. Florence Tem. With due respect, I would like to introduce her. She has assumed this role since 2016 and had made history for the AMREF Health Africa Tanzania, being the first Tanzanian country director in that position, and she had been the first country director to champion the formation of the first local body of AMREF Tanzania. She is not new to serve at this capacity as the country director. Her record starts back where in Ethiopia, where she served as a country director for that country. And later on, she was really willing to bring back her talents and skills to benefit our beautiful country. Dr. Tem has been a role model to many, with a humble beginning of her journey at AMREF as a project manager, head of programs, deputy country director, before she was appointed as a country director. She had served at the Ocean Road Hospital, as well as the Muhimbili National Hospital, before joining the public health space. And she holds a degree in medicine, master's in public health, and a number of leadership trainings. Dr. Florence, kindly welcome to the podium to address the audience.
Thank you very much, Dr. Rita, and hello everyone. I'm not sure it's afternoon or morning, but I'm so glad to be in front of you. Actually, it's my pleasure to congratulate also the Tanzania Health Summit organizers to recognize the importance of partners and different players in the country. And for that sake, we as AMREF got the opportunity to stand here before you. So it's really our pleasure and it's an opportunity for us. And again, I also want to thank our funders, CDC and many others, who have enabled us to be among the pioneers in the global health security space. And as Rita said, we started doing this a couple of years back, much as it's becoming now a very prominent agenda. For AMREF since 2009, we had the opportunity to pilot a community-based surveillance in Mkuranga. And through that experience, by 2015, through CDC support, we were able to do more of community-based surveillance in the border regions, starting with Arusha and Kilimanjaro, and then went further to more, actually now I think 8 regions now. And we have our panelists who will tell us more about that. But I must say, of recent, we have launched our new strategy, which will run for the next 8 years, with a lot of revision, etc. And one of the main strategic platforms that we are going to address is around social determinants of health. And that's where the issues around global health security will fall into that. And we have a very specific objective that's going to address, it's about supporting readiness of health systems for early detection and rapid response in outbreaks or pandemics, so to speak. And we are also building on experience. And I'm very happy to say that through that experience, we've been able to train a number of community health workers, and we have one here as a representative, in doing event-based surveillances. And it's done also electronically. And of recent, I think you remember, on 16th March this year, there was an announcement through the media of unknown disease that has emerged in Kagera region. And by 23rd or 21st there, it was confirmed to be a Marburg disease. And the person who actually picked the first signs was a community health worker. And she's here, Vedastina. It was through the same community-based surveillance, the same event-based surveillance system, electronic, she was able to alert the rest of the system, and there was a rapid response. So as AMREF, through that process, we are expecting, and this is actually coming along with the primary health care. We know that with universal health coverage, we still have to make sure that our primary health care is really set. But with emerging outbreaks, if the primary health care is not resilient enough, even the universal health coverage will never be attained. And so we are aiming at strengthening more on the surveillance systems and also facilitating rapid response, and also continue to work with the One Health approach. We have been working with the One Health desk through the Prime Minister's office, PORAG, and the Minister of Health, and with, again, the support with the different partners, including Africa CDC, but also CDC in Tanzania. So we are really appreciative, and we see that this is a time that should be a common knowledge, not only within the health sector. It's a multi-sectoral issue. At the same time, our community awareness and knowledge has to be should be known across. So increasing awareness of our outbreaks and such of common conditions that need to be reported immediately is something that we embrace and think we need to continue. And also integrating in existing services. So in doing that, we're going to address through the main pillars of health security. That includes the leadership and governance, but also community engagement, and I've already mentioned surveillance and disease intelligence, and there's also essential health services and laboratory diagnostics. We have been working through those space for a couple of years with the different experiences, and that's why we have our panelists here. We'll be able to share some of the experiences. I understand that time is not enough. I'm not trying to look at the clock there. I don't know how many minutes I've used already. But I know we have a lot to hear from the presenters and also more to contribute. So again, it's an opportunity for us to make a reflection to the experiences that we have gone through. We've gone through Ebola, we've gone through Marburg, but there are other diseases that we also report on, including anthrax, Rift Valley fevers, all those outbreaks that we might not come to the surface, but we're at least around 80,000 alerts have been made through this system. So it's really a workable system and should not underestimate the power of community health workers. Thank you so much and looking forward.
Thank you so much, Dr. Temu. Very well set and very well aligned with the current AMREF strategy and the effort that the government is taking through strengthening primary health care to attain the universal health coverage that aligns very well with the theme of this summit. I would like to take this opportunity now to introduce the panelists. We have Emmanuel Mwakapasa, who is a nursing officer with a specialty in field epidemiology and critical care. His experience records over 14 years in technical and strategic leadership in health workforce capacity building and 6 years in surveillance and response to public health emergencies. Mr. Mwakapasa works with the Ministry of Health as the national level event-based coordinator, and he had made records in spearheading the establishment of the EBS system in Tanzania, including development of a number of guidelines, training materials, as well as electronic reporting system and rolling out of the EBS in over 60 districts in the country in 14 regions. His competencies lies in disease surveillance, outbreak response, infectious prevention, leadership, data management, and scientific communication. Together with him, we have Mr. Selemani Yondo on my left from the President Office, P.O. Raj, who is the Environmental Health and Sanitation Coordinator and has over 10 years experiences working with public health. He serves as a Senior Surveillance Officer at P.O. Raj, and he has a massive experience with community health-based intervention related to surveillance and WASH. He had been very instrumental in the response to COVID-19 when we had the outbreak in the country. He had been sitting in a number of project coordination teams, including the one that was implemented by the Ministry of Health, P.O. Raj, and AMREF in partnership with UNICEF to safeguard the continuity of essential healthcare services. We also have our guru, Ms. Lusungu Ngailo, who works with AMREF, with a record of over 15 years experience in community-based interventions, and in particular for community-based surveillance, HIV laboratory, capacity strengthening, operational research, proposal development, and championing of the community-based surveillance program in Tanzania. Lusungu has worked with AMREF for a prolonged period of time in project implementation and pioneered establishment of the CBDS project in Tanzania at Mkuranga district, which had led to the EBS implementation also in Tanzania. Additionally, throughout her career, she has successfully applied her skills on capacity building to train laboratory workers across the country, technical ability, aided in development of various national guidelines, including EBS, community-based surveillance, and guidelines. Together with them, we have the community health worker, whom I'll take her pleasure to introduce her when her time to speak arrives. So we jump straight to hear from Mr. Mwakapasa from the Ministry of Health. Can you please share with us the key milestone that the country has made throughout its journey in the establishment of the event-based surveillance in Tanzania?
Thank you very much, Madam Moderator. Yeah, before talking about the milestone, to put you into context, let me say something about event-based surveillance. Event-based surveillance is continuous monitoring, detection, interpretation of events or of alerts. Hello? Of alerts that may pose risk to human health. And these alerts can come from diverse sectors, spanning from animal sector, environmental sector, human health sector, and other sectors. So event-based surveillance encompasses the idea of One Health. So it's a new, actually it's a very good thing as a country that we have started. So event-based surveillance was started way back in 2016. Actually, this follows the recommendation of joint external evaluation, which actually recommended that we should strengthen event-based surveillance, because it was found that we are good in indicator-based surveillance, but in event-based surveillance. So the IDSR system had strengthened. So as a country, we decided now to embark on event-based surveillance. So in the process of embarking on event-based surveillance, we actually developed tools like guidelines. Now we have a guideline, event-based surveillance guideline, but also standard operating procedures, training materials, monitoring and evaluation framework as well. And on top of that, now we started rolling out it to regions, focusing more on the regions, on the border regions. And we actually, up to now, we have rolled out event-based surveillance to 14 regions in Tanzania. And we have trained also community health workers, more than 4,000 community health workers, and more than 2,000 healthcare workers. Also, we did advocacy to regional and district leaders on event-based surveillance. And also, we sensitized village leaders like village chairpersons and ward executive officers. So now the community where we have rolled out event-based surveillance, or where we have rolled out event-based surveillance, is now vigilant. As you can see, we have started getting actually alerts from those regions. And another milestone worth mentioning is we also developed electronic reporting platform. Previously, we were doing a paper-based, and now we developed electronic platform. And this electronic platform, actually, the community health worker use mobile phones in reporting of alerts. And actually, it has proven a very good success because the reporting rate has increased. Now we are getting around 70 alerts per day, as compared to previously when we were using paper-based, we were getting only 17 alerts per day. And also the alerts that we are getting actually come in a real time. So this actually help us to do actually response in a real time as well. Another milestone worth mentioning is now we have started doing media scanning at the national level. We are doing media scanning on a daily basis. We use epidemic intelligence from open sources, a tool from WHO, and other tools as well. So we do media scanning, but also we have hotline. The hotline, which is functional 24/7. There are people who are actually receiving calls from the public, and through those calls, we also get alerts. So this is also something worth mentioning as a very good milestone that we have achieved. And another thing, we have established alert desks in the regions. Up to now, we have 6 functional alert desks, where now we have people in regions who are actually watching of all alerts emanating from their respective regions, and do verification and response to those alerts. Yes, so this actually is milestone worth mentioning. Thank you.
Thank you, Manuel. Very well elaborated the milestone, and I would really like to hear from Lusungu now. How does the Global Security Agenda project fit into the milestone that we've just heard from the previous speaker?
Okay, thank you, moderator. Good afternoon, listeners. AMREF, as the previous speakers have spoken, AMREF has been part and parcel of these milestones from the beginning to now. We have been there from the development of the collection tools, from the training materials, the guidelines, the rollout of the guidelines in those 8 regions. We started with the piloting in Kilimanjaro and Arusha. And from there, then, from the lesson that we learned, we scaled up in other regions that are borderline. But also, we have contributed in the management of public health events of international concern. As the previous speaker said, we have managed several public health events of international concern, such as anthrax in Ngorongoro, and others like MVD in Kagera. We have managed other outbreaks like cholera outbreaks in Dar es Salaam, and they were managed in a very short time. And also we have contributed in the strengthening the community structures. We have sensitized the community leaders by engaging the communities from the initial stages of the project, so that we have the ownership of the project at the community level. And this is what AMREF is being doing in wherever we are going. We started the community level, strengthening the community structures, the community leaders, the community health workers, and it's like not one shoe fits all size. We go with the community culture. Like when we go to Ngorongoro, we start with the Laigwanans. We don't go to the local leaders, the village chairs. We start with the Laigwanans, and then we go to the local leaders at the community. And they are the ones who are spearheading the project at the community level. So we have done this together with the government from the scratch up to now. And all the 14 regions, from the 14 regions, AMREF has rolled out the event-based surveillance in 8 regions out of 14. And out of the 4,000 community health workers that the government has rolled, AMREF has trained 1,400 community health workers. In those alerts that we've managed for 2 years, we've managed 84,000 alerts. So AMREF has been part and parcel of the government in the spearheading the event-based surveillance in the country. Thank you.
Yeah, so before I move to the next panelist, probably could share with us best practices and lesson that you've gathered throughout the implementation in Tanzania.
Okay, talking about the best practices, the project itself, the system itself tells about early warning and rapid response. So all through the implementation, we've seen the improvement and the strengthening of the early warning from the regions that we are implementing. I can take an example of the region like Songwe. Songwe is bordering Zambia. We had cholera in Zambia, so we ensured that Songwe is very well prepared so that they cannot get the outbreak from the nearby country. That is one of the success that we see. Another success that we see is the uptake of the project at the regions. As I said, we are engaging the communities from the initial stages of the project. So we have examples like Ngorongoro, Kigoma, Buhigwe DC and Kibondo DC. The government there, the local government, the districts, the regions, and even the local governments, they have taken the projects because we are not paying the stipends to the community health workers, but we are sensitizing the regions and the districts, but also the health facilities to set aside some funds to support the community health workers. So in those districts like Ibuhigwe, Kibondo, and Ngorongoro, they now have plans to pay the community health workers when they are working with them. So also to me, it's a success. Yes.
Great, thank you. So I'll move to Selemani. From the PRAJ, I know you are the ones who are actually overseeing all the implementation at the primary healthcare level and community structures being part of them and community health workers. How do you find the engagement of community structures, including community health workers, contributing to bridging the gap between the informal health system and the formal health system with regard to the management of public health threats?
Thank you very much, Daktari, for giving this opportunity. Actually, community health structures are very important in public health emergency management. And actually what we need is to ensure that our community systems are able first to detect timely these alerts and report to higher levels so that the response can be taken within the time. And the community healthcare workers have been doing this work very efficiently, as the evidence was provided from the beginning of this session that even the Marburg first incidence was reported through community healthcare workers. So this is, it's very important to have this system which is enabling us to detect these alerts and being reported so as can be confirmed. The second thing, I think the health system, community health system is assisting particularly in providing responses that are reflecting the needs which are found within the communities. Why? Because within the communities have different needs. And within the communities there are different disparities. So these disparities can be easily identified by community health care workers. So as this information will enable us to design the response intervention that addresses the needs of different people within the communities. So for the experience and the evidences we have, for example, in Ngorongoro, wherever you start, you want to design an intervention to address an emergency management within the community, you should consider the needs of the people within those communities. And this information is you can get from community healthcare workers. So this is what actually we see. Another thing which community health workers are supporting a lot, according to the experience we had in this program, is that during the implementation of preventive measures toward these health emergencies, the community health workers, they were able to go to the community, provide health education, influence some behavioral change to their people. And the people were very easy to accept what they have been told by the community health workers. Why? Because they trust them, because they belong to those communities. So that essence of them belonging to the community is what makes the community to have confidence with what they are told in terms of how the diseases are transmitted, what behaviors are supposed to adapt. And they did a huge work during the prevention of COVID-19 throughout the country. And actually, another thing I wanted to say is about now as a PRI, we think that the sustainability of these community structures is very important. And how can we achieve this? One, I think we need to have to harmonize the activities which are done by community healthcare workers. This will enable these community healthcare workers to have a certain package of activities that they have to do within the communities. And to ensure that the activities which are addressed by different programs to be harmonized so that they can be done by one community health worker, rather than different programs having different community health workers. The second is to ensure there is sustainable financing for community health workers. There within the community healthcare facilities like dispensary and health centers, to ensure that we have funds which we allocate for providing payment for community health workers. And already there is evidence, as my fellow speakers have said, there are facilities who are able to pay for this, for the work they are doing in the community. So I think this is another issue which we have to be done. And another issue, I think it is continuing supervision and the capacity building to update them with real what is happening in the world in terms of health emergencies, and also conducting some periodic orientation so as to strengthen their capacity so they can deliver their activities very well. Thank you.
Thank you, Selemani. Very, very well put. The linkage between the community and why is it important? Because we have localized solution for the particular community, and being able to tailor-make the solutions that we are going to address the particular challenges. I'll go back to Emmanuel, and I would like you to tell us what are the challenges that are still remaining or that you are still seeing as we are implementing the event-based surveillance system in the country.
Thank you. Actually, the challenges. First of all, EBS, we want to roll it out to the whole country. But now we have rolled out to only 14 regions. So we still have a work to do. So the issue now is, funds for rolling out the EBS to the whole country. We need to do that. It's very important. But also to integrate it with other existing surveillance systems. We have a system, electronic EBS system, but we would also want that system to be integrated with other systems, like surveillance system from animal health sector, environmental health sector, and other sectors. As I said previously, EBS encompasses the idea of One Health. So we want also to get all the alerts coming from different sectors. So we want to integrate the system. Also, to have like a guideline which actually is stipulating the issue of One Health, the issue of One Health. The EBS guideline, but focusing more on the One Health issues. So, so the challenge is like now the ministries, actually we're working on silos, Animal health sector is doing their own surveillance, human sector doing our own surveillance. But mind you, we have the nurses. So, we would also want to know what is happening to the animal sector. Also, we would also want to know what is happening on the environmental sector. So we really need to integrate the system. Yeah, thank you.
Thank you, Emmanuel, for sharing the challenges, and probably I can also call them the opportunities that are lying ahead to continue strengthening the event-based surveillance in the country. And I'll pose the same question to Selemani, who is overseeing from the PORAD and monitoring all the implementation at the community level. What are the remaining challenges that needs to be addressed?
Okay, thank you very much. I will not be very far from what Emmanuel have said, but one of the challenges is issue of harmonization. We have different partners who are actually working with community health structures, community health workers. So what actually we want to harmonize these activities. So we have that challenge of harmonization. So every partner have his or her own community health care worker. So that one becomes very difficult to integrate those activities. And another way is to ensure, I was talking about issue of financing. So we want every partner who want to support the community health structures to ensure we are supporting through direct health facility financing. So everyone, if it is paying a different amount to different community health workers, so community health workers become community health workers of AMREF, of path, of HPSS, of someone else. So that way, the sustainability become a problem. For us, we think we have to agree that we have a certain token which should be provided to a community health worker per month. And all other partners who want to finance for payment of community health workers should direct their funds to the facility, the catchment facility, which is there. And the payment will be done from there to the, and that payment should be uniform all over to the community health care workers who are found within the same council, with the same region and the same nation. I think these issues, if can be addressed, will prevent the idea of every partner having community health worker. Thank you.
Thank you. Back to Lusungu. And can you please tell us now, looking forward, through AMREF and other collaborators who you are working with, how do you see your continued engagement in collaborating with the government for prevention, preparedness, and response of public health threats?
Thank you, Dr. Rita. As we have seen that AMREF has just launched its strategy of 8 years, and one of the strategic pillars is the social determinants of health. So we are looking at the social determinants of health, and in all areas, all the prevention, detection, and reporting and response of all the public health events, but also any event that is happening. So AMREF is working on those areas, especially in the, our project is working in the detection area, but we also have the prevention, but also the response area. We are working in the programs that are dealing with the vaccination. So I see AMREF will continue to support the government in the prevention of the public health threats, but also in the responding of the public health threats using the community structures that we are capacitating at the community level. Thank you.
Thank you. Before we go back to Emmanuel, I would like us to hear the voices from the community, which is the first-hand experience, from Vedastina Shumbusho, a community health worker, who will provide us with a vast experience in implementation of event-based surveillance as a community health worker. She had been doing that role for the event-based surveillance for 2 years, and she resides in Bugabo Ward, Nyalima Village in Kagera, DC. And she's attached to the Kiamalange dispensary as a reporting site. Vedastina also had been trained through CDC support and had received training on EBS as well as electronic EBS on early detection and reporting of public health threats using the Ministry of Health guidelines. And during the EVD preparedness, she also received some updates. Vedastina heard about the report of a death of unknown cause that occurred on March 15th from a nearby village and took an effort to report it in the electronic event-based surveillance system the early morning of March 16th in 2023. The reported alert was later declared to be MVD outbreak, and we find that she played a crucial role in alerting the system and hence the response to the MVD outbreak. Vedastina, karibu. Na tunaomba utueleze uzoefu wako kufanya kazi kama mhudumu wa afya ngazi ya jamii katika kijiji chako cha Nyalima, lakini pia ni jinsi gani ambavyo ulishiriki moja kwa moja katika mlipuko wa ugonjwa wa Marburg katika mkoa wa Kagera. Karibu sana.
Asante. Kwa jina naitwa Vedastina Shumbusho Vediani, natokea kijiji cha Marange, kata Rubafu, tarafa Bugabo, mkoa wa Kagera, wilaya Bukoba DC. Ni mhudumu wa afya ngazi ya jamii katika kitongoji cha Nyakalima. Nalipotia katika kituo cha kutolea huduma cha Marange dispensary. Ilikuwa Novemba 22, nilipata mafunzo kupitia AMREF, CDC pamoja na Wizara ya Afya jinsi ya kuripoti magonjwa ya mlipuko. Na niliambiwa nikipata tetesi ya magonjwa ya mlipuko niitume ndani ya masaa 24 panapohusika iweze kuchukuliwa hatua na kufanyiwa kazi. Asante.
Na unaweza kutueleza zaidi ni kitu gani kilikupa msukumo wa kutoa taarifa ya tetesi ya ugonjwa usiofahamika ambao ulitolea taarifa siku ya tarehe 16 mwezi wa 3 mwaka huu?
Ilikuwa tarehe 16/23 nilipata tetesi katika njia ya WhatsApp kwenye simu kwamba katika kijiji Maruku kata Kanyangereko kuna ugonjwa umetokea wa mlipuko usiojulikana chanzo. Kwa kuonekana nilifundishwa, nikapewa na simu kama kitendea kazi, nikabidi niitume hiyo tetesi panapohusika ili iweze kufanywa kazi. Na washauri wahudumu wa afya ngazi ya jamii wakisikia ugonjwa wa mlipuko umetokea, wasikae na hiyo tetesi, waitume haraka ndani ya masaa 24 iweze kuchukuliwa hatua na kufanywa kazi. Asante.
Na kama unaweza ukawaeleza washiriki ni kitu gani hasa kinachokupa msukumo kufanya kazi kama mhudumu wa afya ngazi ya jamii na hususan kutoa taarifa hizo za tetesi ambazo kila wakati unatoa taarifa na zinakwenda Wizara ya Afya kwa ajili ya kufanyiwa kazi? Kitu gani kilichokusukuma ama kinachokusukuma?
Kwanza kabisa nafurahia kazi yangu. Kitu cha kwanza, jamii imenitambua na nawatambua na inaitambua jamii yangu. Kilichonisukuma nitume hiyo tetesi haraka, nilifundishwa mafunzo ya kutoa tetesi ya magonjwa ya mlipuko na nilipewa mafunzo hayo siku moja. Kwa hiyo niliposikia hiyo tetesi ya magonjwa ya mlipuko nikasukuma niitume panapohusika ili iweze kufanywa kazi. Nafurahia jamii yangu mpaka sasa hivi iko salama na nitaendelea kuilinda jamii yangu. Asanteni.
Asante sana Vedastina, na ni kweli unafurahia jamii kwa salama, utaendelea kuilinda. Na kutoka kwenye hiyo sentence yako ya kuendelea kuilinda jamii, kufanya iwe salama, I'll shift back to Emmanuel and kindly share with us all the recommendations or opinion looking forward to strengthen the event-based surveillance in the country. What are the recommendations, or what is your opinion?
Thank you, moderator. Yeah, actually, the recommendation here now is all about to increase the vigilance of the surveillance system. Now, Christina is a vivid example of a lot of community health workers whom we trained out there, what they are doing. So we want to roll out this community, EBS to all regions. But also, we recommend also, to engage the whole public, because now we have 199 number, the hotline, toll-free hotline number. We also would want this to be known to the general public, to make general public aware of what and how to report. And this is easy. We can just do posters, making community aware of what and how to report. So we'll increase the vigilance of the surveillance system. Is also more community health workers. Yes. Thank you.
Thank you. We still see that community health workers are vital, but also the general public is important, because for the example of Marburg outbreak, we remember the border rider was the one who is shunting patients, and they were dying along the way from the facilities. So it is important for everyone in the general public to get note of this toll-free number 199 and provide any alert that is available that is threatening to the health of human beings. Selemani, from the PRI perspective, we've heard the voice from the community, the experience from Vedastina. You've clearly highlighted the need for sustainability of financing the community health workers, but also harmonization of community health workers package. Do you see any other opportunity in addition to the two that we can strengthen to ensure that we have a responsive system with regard to the public health rates?
Okay, thank you very much. I think something which we can add among the two recommendations, it is to ensure community engagement and participation, and to increase more awareness to the community in terms of understanding about EBS, and understanding the role of community health workers. We know they know, but we need to strengthen more this, because when community takes ownership of this community health workers, is where now they can recognize them, because they have different forums. There are community health committees which are available there, so they have to recognize that community health workers are the one who are representing them in terms of notification of health events. So this is very important for the communities to take lead in this process, because this is community-based initiative. Yeah, thank you.
Thank you, panelists, all of you. And in summary, we've had the journey of the event-based surveillance in the country since time memorial of 15 years in 2009, when it was piloted in Mkuranga, and later on we had a support from CDC strengthening the surveillance system at community level up to today. And we've seen a number of milestones that we've taken. Guidelines are in place. We also have the electronic reporting system, but also a toll-free number that we can all access and report. And one of the success that we have through the electronic reporting is now we are seeing a number of alerts reported on daily basis have increased from 17 to 70 in a day, which is promising. Also, the Ministry of Health is conducting media scanning using the epidemic intelligence, working with the WHO. But also we have functional alert desks, though in few regions, but they are functional, and those are the priority regions. And there's a lot to be done ahead, looking forward on the sustainability for financing community health workers, also embracing the community structures, but also harmonizing the activities. I would like to open the floor for the participants. If you have questions or recommendation or any comment for further discussion, karibuni.
Thank you very much for this wonderful discussion, and it's glad even community health worker is among us, and this is giving the congratulations to AMREF. I've seen you have been a pioneer of community engagement and community health workers in Africa. Just by experience, we have seen that the practice of community health workers has been just program-based or disease-based. And now we have, it's the first time I'm hearing that we use them as in surveillance. How best they can be integrated to have a joint that community workers are minimal package of areas which they see, or is it based that, for example, in surveillance, they perform surveillance and others focus on other things? And for EBS, just for highlighting, Is it operating different from other channels like few public health emergency operating centers? Or does it go direct to prime ministers? Or also, how does it operate?
Asante sana. I would like also to congratulate AMREF for this initiative, but also for the panelists for a very informative information or presentation they've given. As the presentation were done, some questions were running into my mind and I would like to share so we can discuss. Regarding this digital platform for reporting or giving alerts, I would like to know how many false alerts are normally recorded, because when people get free kind of access to such kind of service, sometimes they abuse it. And if they are happening, how does the system or the system administrator control this kind of false alerts? Regarding the toll-free line, I believe you are referring to the AFIA call center. Would like to know as well how many calls are normally received apart from the other digital format in terms of reporting some emergencies. The other question goes to Suleiman regarding the linkages between the community health system and the formal health system. What happened in the area where there is no public health facilities? How is this community linked to the formal health system? But the other question now goes to AMREF and PORAG as well as for the Minister of Health. You have this program that is running and it seems to be very promising. Have you done some kind of cost analysis to see what are the cost drives and how they could be adopted by the government? Because we have got many programs of using community health workers, but by end of the day, they are not being absorbed into the government system because of the different costs. Today in the morning, we were in a different forum. We were informed that different organizations compensate differently the community health workers, and that becomes very difficult to sustain these programs. So these are my questions. Asante sana.
Okay, thank you so much for presenters. I just wanted to ask a question for AMREF on, so we've been using community health workers, but it has been a challenge in terms of reporting. The reporting system of really identifying the value and the work that certain community health worker has been doing. So the reporting system, is there a way that we can have a system that is very unified or monitored even by the government system, in terms that these community health workers can easily report on what they have done, whether it's throughout the week or throughout the day, just to make sure that we are clear of the result, the performance-based achievement of whatever they're doing. So it has been a challenge. You're working with several community health workers, but if in a case you're asked, okay, what is the report, maybe a monthly report? I know we had there's a system that they have to be reporting, but it's not well placed. So maybe just to strategize and think through as partners and discuss how best can that work for us, because it has been a challenge working with them reporting on what they have already been doing, maybe in a month or 3 months or 4 months. Thank you.
So I will let the panelists respond to this first set of questions, and then if time allows, we'll have another round of questions. We'll start with Mr. Mwakapasa, and then we'll go to Piora, then Lusungu.
Thank you. Thank you for the questions. Maybe to start with the integration of community health workers. Asked about if are they working in some program-based? The answer is no. Now currently, CWs whom we have trained, actually they are doing other programs, you know, like HIV, malaria, you know. So they are not solely for surveillance, no. And currently we are developing an integrated curriculum. As you have heard yesterday, the Honorable Minister for Health mentioned that actually we are in a plan of recruiting a lot of community workers. And the curriculum development is in a process. And that curriculum actually will have issues like maternal and child health, HIV, surveillance, and so forth, malaria. Just a minimal package for community health worker to understand. You know, so a community health worker will be an integrated person. He or she will do a lot, actually, surveillance issues, you know, malaria and so forth. And sure also sustainability. And how does CBS operate? Does the alerts actually, do the alerts reported going straight to maybe to one health coordination desk of Prime Minister or EOC? Now the answer is, you know, as I said, we are now doing electronic EBS. So a CHW, once, you know, detected an alert, log into the system, and that information goes straight, actually it goes to all levels, from health facility, council, region, up to national level. But, you know, up to the Minister of Health at the national level. It doesn't, actually, that information doesn't go to Prime Minister Office, no. But the EOC, you've mentioned a very good thing. Now the EOC, we are also in a plan of having, you know, regional EOCs, regional alerts, regional public health emergency centers. And within the EOC, there is a watch desk. So all those alerts are reported, emanated from the respective region, will be seen by the watch desk at that EOC, and also will be managed accordingly. Regarding the digital platform, how many false alerts and how are they controlled? In EBS, you know, we can say false alerts, but, you know, alerts is alert. Or sometimes we call signals. Signal is verified information, and we encourage the public to report. We really encourage. Let them report. Our task is to verify that information. Only that. So we actually encourage them to report. We don't bother if that information is coming, you know, is false or not. Our issue is to verify. So I can't really tell the number of false alerts or false signals. There are so many, because, you know, the system, EBS system, is more sensitive, and it should be so. More sensitive to capture a lot of alerts. Okay? And that is the one of the, you know, quality of this EBS system. It should be more sensitive. So, the issue of, you know, cost analysis, maybe my colleague also will help to respond on that. But EBS, we started EBS not just as a parallel service system, no. EBS is within existing IDSR, Integrated Disease and Surveillance and Response System. So EBS is merged within the structure, existing structure of surveillance. There's no duplication of effort or even cost. So EBS is running smoothly within the existing structures. So we haven't done the cost analysis per se, but as I'm talking, we haven't seen any difficulty of implementing EBS because it is within the existing surveillance structure with no additional cost. I think I've answered my part. So thank you very much.
Yes, Emmanuel, only one question on the toll-free number. How many or other types of reports that are being received through that number apart from the health alerts, if you're aware of that?
The toll-free number is not only for EBS or alerts. Also toll-free number is all about giving people. Some people do ask some questions. Need some clarity. They're reporting maybe enemies management. Regarding as far as healthcare is concerned. So it's it gets a lot of information actually from the public. But we filter, we take ours, only signals or only alerts that now we take them and we work upon them. And other information is channeled to the appropriate section, maybe curative services. If somebody is complaining of care, then it goes to curative services. So we are getting some such information from the public.
Great, we'll move to Selemani.
Okay, thank you very much. I have some concerns from Al-Kebi about the linkages between this informal system, that is community health worker system within the community and the healthcare facilities, and particularly when it happened now within the particular community or in the certain village, there is no healthcare facility, specifically public healthcare facility. What actually is done? One is, first of all, these community health workers, they have their mentors, their supervisors within their healthcare facility. We have one designated nurse or a health officer or a clinician within that facility who is the CHW coordinator. So the way the facility they operate in terms of catchment area. So the facility, even if the village have no facility, but it is a catchment area of a certain facility and a certain population. So every healthcare worker, all healthcare workers are attached to a particular, to their catchment healthcare facility. So they report to that one. I know there are some needs to be addressed because when now facility is a little bit far, there are some needs to be addressed for the community health workers to be able to report and also to be easily mentored because there are issues of transport challenges. But the arrangement of itself, the system, it is in terms that one health facility saves certain catchment area. So even those villages which have no facility, they are within the certain catchment area for the health facility, and there is a supervisor for community health care workers. And this issue actually of different organizations compensating differently community health care workers, I also mentioned as a challenge. And the way forward on this, we say that we need to harmonize the rate actually we are supposed to disburse back to community health care workers. We agree on the certain rate, and that should be paid uniformly, and it should be paid through the facilities. And this can be ideally achieved through joint planning, joint annual planning within the facility. And in the facility planning, we have what we call the cost centers for planning. And in every facility, we have cost center for community initiative. So it's where now you put all activities which are related with the community issues. So what actually it is important is to integrate the plans of partners and the government together if you are working to a particular facility, so as all the payment for healthcare workers should be channeled through the facility. So the issue here, I think now, maybe partners have their needs, the government have their needs. Now we harmonize their needs. And sometimes it's confidence. Now we are here to provide the confidence that our FAST system is working very well and it can be used to pay community healthcare workers. Thank you.
Great, the FAST system is working very well. I underscore, and it can be used to pay for the community health workers, as the experiences that we've heard from the lake zone regions, Mwanza and Simiu, where AMREF is using the DHFF system to pay community health workers, and it is working very well, with some improvement that have been made with the Ministry of Health and PORAJ after giving the feedback. Lusungu, please go ahead.
Thank you, Dr. Rita. I will respond on the how to get the reach from the community in a sustainable way. What AMREF is doing, we know the community health worker need a lot of engagement. So we came up with strategies to engage them more. So we have the WhatsApp groups, and in the WhatsApp groups, there are community health workers, but also there are healthcare workers, and we have the regional and district coordinators that we are working together, even the government coordinators, that we are working together to capacitate the community health workers. We mentor them, but we sensitize them on reporting of alerts that we get. So we have the electronic system, but we have not rolled out in all the country. So where we are using the paper-based system, we encourage the community health worker to report through the in the WhatsApp groups. And the system that we are using is the government system. So they are reporting just in the normal channel, the IDSR system in the health facilities. That's how we manage to get the data. Thank you.
Great, so we can get another set of questions, at least 2 people, then we can be closing the session.
Hi, thanks for this opportunity. My name is Happiness. Just wanted to ask one question. And first of all, I'd like to congratulate you for a good presentation and a good work that AMREF is doing. Mine is not specific for the emergency response, but looking at the CHWs as whole. And I think it is going to Selemani. I know we are speaking about UHC, and we know the role that CHWs are to play in taking forward this agenda. And as much as UHC is concerned, it means we are having this community that can freely access the services. But when we have this kind of very important people working at the grassroots, what initiative do we have to make sure that they are also covered and they are also protected, and they don't don't access services because they cannot afford it? So as we are looking forward to the packages, to having them integrated into the system, or even through as partners, is maybe how do we look forward to make sure that as we are engaging them, we also make sure that we are taking care of their health? Because when we cover them, when they can access the services, it is also easy for them to motivate the community, and the community learns through examples. So it will be easy for them as well to actually join or utilize our insurances and make sure that the community is covered as whole. The second one is just a follow-on from when we're speaking about the cost analysis of the community health services. I know most of the time we speak about how costful it is to kind of make sure one community health care worker is working, but maybe when we're looking at the cost, we should also be able to see we are comparing that cost to what, because we are comparing it to a life that is going to be lost. So as you're doing the cost analysis and finding it expensive, we should also think of the families that also can easily lose life because of missing a simple preventive measure. So that is my contribution. Thank you.
Thank you very much for the presentation. But I would like to direct my question to AMREF. Now that AMREF is focusing on pilot regions and looking forward to engage, work with the community structures within the public in those regions through digital means. Now there is an opportunity through Afya Core. How do you see yourself partnering or linking somehow so that you can cover the whole country, because the Afya Core uses facilities, digital facilities countrywide. Now I want to know the position of AMREF to use the service provided by Afya Core to facilitate their input to cover the whole country. Thank you.
Thank you. I'm Catherine Sanga. I just want to say that we appreciate the session, and we are delighted to see Vedastina with us. And I would like to ask all of us to stand and appreciate the work she did to help us on this issue of Marburg. So before we end the session, I will appreciate if we can stand and thank her by giving her a clap of thanks. Thank you.
Thank you, we'll do that. She has another slot, and then we'll be able to really acknowledge her contribution. With her support, we are able to combat the outbreak within a very short time, and it had made history across our borders and across over the continent. So we have 2 questions. Selemani, you can start, and then we can have Lusungu.
Okay, thank you very much. Actually, I was not expecting this question to come, but it's a very helpful question. These community health workers, they are actually working, it is true, they are assisting a lot, particularly, for example, implementation of different disease control measures within the community. They are also assisting like in contact tracing during the outbreak. They are moving house to house to trace the contacts of diseases. This means these people are exposed to different conditions, different diseases, and particularly even for those communicable diseases. So we need to understand that if they are working, their work is like they're exposed to a certain risk. So once they contact an illness, can they access healthcare services without any financial difficulties? That's a general question Happy was having a concern. And I think this one we have, as a government also and the partners, we have to think now particularly on this, and see when we are making some incentive package for the community healthcare worker, we should think also on covering him, because his or her work actually put him or her at risk of contacting different diseases. So for now, I just thank you, Happy, for this concern. So when we will be developing the essential package for community health workers, I think this is one of factors to be considered. Thank you.
Thank you. As we are transitioning to Lusungu, I would also like to get Dr. George Mgomela prepared for the closing remarks once we are done with the discussion. So Lusungu, please go ahead.
Thank you. He asked about the Afya Call. How can we maximize the use of the Afya Call Center? Yes, we want now to make EBS viral by advertising every region. We plan to use the posters, radios, so that everyone can be aware of the event-based surveillance. Because the 199 number is also integrated in the electronic system. So it's not only about calling, it's also about messaging and it's a USSD messaging, which is free, and also it can use even not a smartphone, even just a simple phone, someone can send a message. So we want to make it viral using the media channels so that everyone can be aware of the event-based surveillance, and they can use also the AFIA call center by calling. Thank you.
Thank you so much, dear panelists. As we're transitioning to the closing session, would like to at least get one remark from each one of you as a takeaway to all of us. And I will begin with the community health worker who had made every one of us in the country very proud that they are significant and their role is very core for health security in our country. Vedastina, ninakukaribisha tena na una lolote la kutuambia ama una ombi lolote kwetu ama kwa serikali ili kufanya kazi yako iwe nzuri zaidi na uweze kuifurahia.
Asante sana. Mimi ombi langu, unajua hii ni kazi ya kujitolea, haina mshahara. Ningependa serikali au wadau wao wanatuchangia hela angalau ya vocha. Maana uwezi kupata tetesi ukaituma bila MB. Asante.
Yes, it is very crucial, and it aligns very well with the comment from one of the delegates on the floor, taking care of the community health workers in totality, not only using them to provide information or going from house to house. With that, I would like all of us to stand and appreciate Vedastina on the good work that she did in March, and the country is very proud of her. Sasa tunasimama kukushukuru sana kwa kazi nzuri unayoifanya. Thank you, everyone. We'll start with Mr. Mwakapasa for the last word, takeaway, quickly, and then we'll have Selemani, Lusungu, and I'll be welcoming Dr. Mgomela on the podium.
Thank you very much, moderator. Actually, here I'm to appreciate actually the work that AMREF did with support from DC, and that's why we are here. We are seeing the fruits of surveillance. So I also call for other, support from other donors who actually will support now to roll out the EBS to strengthen the surveillance in the country. Strengthening surveillance in the country is also strengthening the global health, security, because now the disease do not know borders. So please, I welcome more support to roll out EBS to strengthen surveillance in the country. Thank you very much.
Thank you very much. Mine is to thank you all our partners actually who you are here, and one thing so as we can strengthen community structures and particularly the intervention within the community. In PRI actually when we are doing this council comprehensive plan, we invite stakeholders. So wherever you are working in a particular council, we want to advocate for the community structure strengthening. Please, when you get the invitation, because we invite everyone to come during the planning, we go and see the planning. I have said we have a cost center for community health initiative to ensure that now we really have some activities which are planned there to address the issues of community healthcare workers. So in doing this, because everything starts with planning, and during the implementation, that's an impact. If you have been planned well or good, then that will be seen there. So please, when we start in December planning, pre-planning activities for the next financial year, please let us cooperate together to make our
Council Comprehensive Plan to be really comprehensive. Thank you.
Thank you. Integration, ensuring we have our plans integrated into the CCHP for a sustainable community health initiative or community health programming. Lusungu, karibu.
Thank you, Dr. Rita, and thank you all for listening. Mine is the appreciation. I appreciate the donors for support. CDC, they have been supporting us all the way, but also I appreciate the government. We have been working together as colleagues. They have an open door policy, which has allowed us to implement event-based surveillance in the country. And lastly, to all of us, let's take EBS as part and parcel of our lives, because when we detect early, we prevent a lot of problems. And we expect emerging and re-emerging public health events of international concern. So we must be vigilant. So all of us should be reporters, not only the community health workers. Thank you.
Thank you. So it's a role of each one of us to report the alerts for a public health security. With no further ado, I'd like to welcome Dr. George Mgomela, who is the Associate Director at the CDC Tanzania, to give us closing remarks, where the CDC Tanzania had been really pivotal in the strengthening of the surveillance system in the country since time memorial, and looking forward, that is still their passion. They are providing technical assistance as well as financial support. Welcome, Dr. Ari.
Yeah, you see? Okay. So it's Chaz Wanga doing his stuff. Thank you. I'd just like to appreciate all of you, but specifically to appreciate AMREF for organizing this forum, and appreciate our colleagues from the government of Tanzania. But just before I close that appreciation, I would like also to recognize my colleagues and friends from CDC. Wherever you are, please raise up your hands. Thank you. We prefer if we are referred as development partners instead of donors. You kind of remove us a bit when you call us that. I'd just like to thank you all, particularly the speakers, Emmanuel, particularly, coming all the way from Wimbledon a long time ago. I'm very happy to see that you are leading this initiative at the moment. But I'd like all of us to think a little bit, what is global health security? Unfortunately, the term security there is slightly misplaced and makes us a bit uncomfortable to discuss that. But global health security is generally some of the activities which we can do proactively or reactively to ensure that certain public health emergencies are contained in a specific places, either a geographic place or internationally. So what Vedastina did was truly helpful in that aspect, ensuring that information is passed on and eventually is supposed to be processed. So I'll still like all of us to give her another round of applause. Thank you. Tunashukuru sana Vedastina. Kama tunavyoelewa ugonjwa wa Marburg ni ugonjwa ambao unasambaa haraka sana. Juhudi zako binafsi zilisaidia sana kufika hapa tulipo. After that, I also like to appreciate our partner AMREF, whom we've been partnering with them from 2015, especially in this global health security, in ensuring that EBS, event-based surveillance, is rolled out in the country. We did in 8 regions, if I did not mistake. And I think we still need to continue this event-based surveillance. Is important. Kama mnavyoona kwa wale wenzangu ambao ni Kiswahili speakers, ubuyu ni mtaji. So any rumor is a capital. So please, all those rumors we have, we should not only pass them in WhatsApp groups, etc. There are formal numbers which have been passed here, and it's important for the government to know. But I'd like also to stress that this EBS system is very important, and it helped us in NVD. However, she reported timely, but there's a time lapse between the time she reported for the time when the index case was really defined to the public, leaving a lot of us maybe potentially at risk. So we need to do something there. And what I think needs to be done is actually digitalization of this system. So Emmanuel, again, I'm pushing this to you. We need this system to be digitalized. Of course, I understand there might be several layers of approvals, but it's important for us to have a digital system where people are able to report information processed, and eventually we launch response to it. Lastly, I'd just like to say that from the US government, particularly from CDC, we are committed to continue working with the government of Tanzania, Puralge, and their colleagues from MOH, together with AMREF and other stakeholders, to ensure that public health events are taken care of, global health security is prioritized, and overall programming in Tanzania. So thank you so much for listening to me. I'm so sorry I was in between you and your lunch. So now this session is officially closed, and you can go and have your healthy snacks. Thank you so much.
Tuwapongeze tena panel yetu led by Dr. Rita. Another round of applause. Pongezi nyingi kwa dada Vedastina kwa kuwa mstari wa mbele kutulinda wote, and we encourage that more. A couple of housekeeping. Make sure that you maintain your badge as we go for lunch. And lunch is served on the 3rd floor in Kilimanjaro. And with that, we thank you all for being so passionate with us, and we welcome you at 3 for the Girl Effect in Mikumi Hall. Asanteni sana, and is there another announcement? Karibu. Kuna hoja? Oh. Kuna hoja kutoka kwa mama. You push all the way. Samani.
Yeah, nimekuwa impressed sana na kazi aliyofanya Vestina na request ya na ombi lake kwa mkutano huu leo, na kwa hiyo nilikuwa nafikiri kwa sababu tuko wa kutosha, kama tukimchangia angalau hata 1,000 tu kila mmoja hapa atapata hela ya kumsaidia kwenda kununua vocha na kuendelea kufanya kazi yake vizuri kabisa. Na shilingi 1,000 nadhani kila mtu anaweza akafford. Asanteni sana.
Mama anasema kazi nzuri inatunzwa, kwa hiyo tumtunze.
Kama mama ninavyoelewa hawa
anatuomba tumtunze mwenzetu Vedastina kwa kazi nzuri. Wakati huo tukienda lunch, Vedastina endelea kukaa hapa mbele, watu tukutunze. Karibuni wakati tukienda lunch, tunapata kwenda lunch.
Community mnapewaga zawadi.
Tumpe zawadi. Asante mama. Kaa hapo Vedastina, wakati tunaelekea lunch tunamtunza na tunakuwa tunakwenda namna hiyo. Asanteni sana.
Hamna muziki. Ukienda vijijini mnapigaga ngoma.
Sasa kimziki.
Sasa MC kazi.
I don't have the equipment. Karibuni tumtunze wapendwa, wakati huo unakwenda lunch. Ukimaliza kumtunza unakwenda lunch. Tunawakaribisha hall ya Mikumi saa 9 at 3 p.m. We have the Girl Effect session on human papilloma vaccination and the prevention of cervical cancer. Karibuni sana, please. Tulioguswa naenda kumtunza dada Vedastina. Asanteni sana. Ndio nafanya hivyo. Wapendwa, hii mikutano ina njaa, kwa hiyo nawakaribisha floor ya 3, keep your badge, Kilimanjaro Hall. Chakula kinakuwa served muda huu mpaka saa 9 kamili ambako ni session zingine zinafuata. Karibuni sana.
ambacho kama na kitu kibaya ambacho unaona event makes everyone happy.
The biggest event is back, East Africa's International Trade Exhibition 2023. Come and connect with companies